Recording in progress.
Good morning, honorable members. Good morning to our team led by Ms. Machalamba. And I noticed that the first presenters are here. FFC, good morning to you too. May we then maybe open our meeting by a short moment of silence amongst ourselves in this meeting. Okay, thank you very much. Honorable members, we meet this week to really be part of what we call the BRRR of the department that we are doing oversight on and the entities that work with the department. We are starting this morning with the presentation from FFC, and we would continue with the other presentations that are for today. Fortunate for us, honorable members, we have had a chance to meet these entities not very long ago, and at least we know now who they are, what they do, and we are here mainly to just get a progress report on the annual performance plans that they introduced to us, match that against what they've done. And some of these presentations have been actually given to us. Just to remind honorable members that this meeting is actually assumed to be within the precinct of the National Assembly, where we are members of, and therefore everything said will actually be in line with that expectation that it is within the National Assembly. The rules that apply to the National Assembly House sittings will also apply to this meeting. Any member would like to actually raise a point or a point of order will indicate by raising a hand and will be recognized. I will need the secretary to assist me in the event I'm not able to see that member. We would probably wish that we refrain from unnecessary point of order and just keep the decorum of the House. I would not raise these points again in our subsequent virtual meetings this week, as we would really still be keeping to those rules of the National Assembly. May I request then the Secretary to do two things to indicate if there are honorable members who have indicated that they will actually either be joining us late or not able to be part of this meeting. The only one I've noticed is the one that I read in our group of Honorable Motubatse, who's having an appointment with the doctor and indicated that he will join the meeting a bit late. Any other apologies, Honorable Ms. Machalamba?
Good morning and thank you, Chair. Present in the meeting is Dr. Dlomo, Ms. Kleko, Ms. Clark, Mr. Mutubatsi, Dr. Tembekwayo, and Mr. Van Staden. I've received apologies from Ms. Sene and Dr. Litlape and Mr. Zungula. Thank you, Chair.
Is Honorable Oshabango also indicated another challenge? Okay. So how many of us, Ms. Machalamba, all in all?
6, Chair.
All right, 6.
Yes,
That's
Chair.
good enough. We can then
Yes.
start.
Yes, Chair.
May I therefore invite you assisting?
Chairperson, I have my hand up.
Oh, I didn't see that on the platform. Yes, Ms. Clark.
Chairperson, just to let you know, Dr. LaRue had a very early appointment this morning meeting, and he is on his way back to his home, so he will join us shortly. He'll be slightly late.
Thank you for that. Appreciate
Thank
it.
you.
Okay. Yeah.
He has just joined, Chair.
Oh, Honorable Dr. Leroux, welcome. Thank you. We've just had an apology that you were going to be joining late. We thought it was really late. Now it's not.
I apologize, Chair. Thank you. I've just managed to join now.
We are just starting and we're taking apologies. Now we are fully in there. So we want to erase your apology in this meeting.
Thank you. My apologies. Thank you.
Yeah. Can we then invite the leadership of the FFC to make their presentations? Ms. Machalamba, logistically, how much time, because members have reflected on this, is mainly to get them to go through it with us, and then we come back for questions. What guide do we have, Ms. Machalamba, for the presentations before we go and engage with the presentation? I suppose, Ms. Machalamba, we have discussed that with the presenters to keep to 30 minutes, 40 minutes, for whatever time that you allocated it. So how much time do you allocate the presenters?
From now, Chair, to 9:40. No, sorry. To 10:20. Sorry.
All right, 10:20.
Yeah.
So they have about 20 plus 20, about 40 minutes. All right, we keep
Yes.
to 35 to 40 minutes. Thank you very much. Can we then have the first presentation?
Good morning, Chairperson Dlomo, Honorable Dlomo, and good morning to all the honorable members of the committee. My name is Dr. Mbava. I am the chairperson of the Financial and Fiscal Commission. It's a great pleasure for us to be in this committee. Chair, I'm also accompanied by the research team of the FFC, who will present the technical aspects of the presentation. Mr. Tandongozo is on the platform, Mr. Tantato, Gianni Deladon, one of our researchers, as well as Mr. Chen Sang, he will also present. For the sake of time, Chair, if you allow me, I want to go to the introduction slide where I just briefly give an overview of what the FFC is all about, who is the FFC and why are we making these presentations to yourself. And then afterwards, I'll allow the research team to go through the technicalities. If you can pause on this slide, Gianni. Chairperson, the Financial and Fiscal Commission is a constitutional institution established under Chapter 13 of the Constitution. Our mandate is very clear in the Constitution. We advise Parliament, we advise the provincial legislatures on all financial and fiscal matters. We have worked with this committee quite well in the past, advising them on the health sector. Our analysis on the health sector has assisted this committee. Other mandates which fall within our ambit, it's also on the equitable share and allocations of revenue across the 3 spheres of government, government guarantees, provincial taxes, provincial loans. All these legislative prescripts, Chair and members, can only be enacted after the recommendations of the Commission have been considered. Without wasting time, I would like now the next researcher to go through the next slide to present. Thank you so much.
Thank you, Chair. This is Jinsane here, and greetings and very good morning to your Honorable Dr. Chair Dlomo and honorable members on the platform. Allow me to quickly, in the absence, unfortunately, of Mr. Tondo Nkosi, allow me to take you through quickly the context within which the health sector, our health sector. Now, just very quickly, is that, of course, our South African health sector is notoriously and well known, unfortunately, for the fact that it is a dual market. We have emphasized this evidence through many of our research, as well as the market research into the sector. Now, this dual market is, of course, one that is, it cuts across multiple lines, unfortunately, of legacies, racial, poverty, between private and public sector, between the affluent and those that are in very desperate situations, and all of it ultimately also cuts across, ultimately comes to the realities of affordability. So despite that, we look at the macro picture. And this is the point, as I said, that we have to recognize our dual market system. In that here, despite the fact that the data is showing we are sitting right there in the middle between those that are in the middle or low income countries and the high income country at the top. But one can read it as that one solid line of South Africa. Actually, within it, there is those two separate lines that are of the realities that is confronting our people. Next slide, please. So don't be fooled, right? Ultimately, by that macro one-line picture, which depicted on the international front. And further to that is our fiscal slippage, and that is our overall, when we mean the macro fiscal slippage and the framework that is under severe strain and increasingly so. In fact, ever since the financial crisis and also, of course, the recent COVID-19 period, the advent, and it has negatively affected our fiscal space, constraining it, and of course, to fund the health sector confronted with the COVID space, is that then we are now in 2024 that we are looking, as we look forward, yes, there will be a slight rebalancing required despite the fiscal space constraints, but there is the accumulated fiscal pressure that one has to deal with as a whole of country and whole of nation facing this, and not just the health sector. But this is just to really show the degree to which that the accumulated pressure on the fiscal space constraining our abilities to reprioritize or prioritize certain sectors, and particularly for the health sector. And as we are doing that rebalancing, one has to take note of that we are rebalancing at the sectoral level. We have to also look at the macro fiscal, at the overall fiscal framework level of this pressure. Next slide, please. So spending on the primary and tertiary healthcare of the alt health sector, these are just quickly to look at the mandate aspect of and some of the challenges I've already mentioned about the health budget constraints have led to a broader array of trade-offs. That's the prioritization, the discussion. Our health hospital system, is where the bulk of the public healthcare expenditures occurs, and these effectively, from an IGFR perspective, that is intergovernmental fiscal relations systems, is implemented across the different spheres of government. And this is quite important because, as you well know, Honorable Dr. Chair, is that national department is more in control of the policy aspects, the governance aspect, and where these more of the primary and so sort of the subnational spheres of hospitals and regional hospitals are more in the hands and of course the accountability of the provincial and even to some extent the lower levels of subnational spheres. And so all of this is one does have to appreciate that it is not just that one department and everybody will rush towards it to complain or to raise issues, but it is a whole of system type and a network of funding mechanisms and implementations that will make this health sector work. It's indeed a very convoluted and very complex system of an issue for quality of healthcare delivered ultimately to our people. Next slide, please. And the audit outcome trend, though I have good news to report, Honorable Dr. Chair and honorable members, is that financial management aspects of the departments did improve slightly. We will look at the actual numbers, the extent to which the under expenditure over the period that, as we have analyzed, showed is quite a bit of improvements on that front. So not so much under expenditures as we've experienced before. Now the question, however, though, is of course with that expenditure, and especially on some of the capital projects, is now what about the results? What about the performance, which we'll look at? And this slide is just to show the overall picture from a AG's perspective, the audited outcome of the health of our health departments and entities. Next slide, please. I think we shall move into the budget and performance analysis. Maybe just to dip into before I hand over to Sabelo, and then after Gianni to take over, is next slide, please, is to look at the budget of the National Department of Health. Focus of the health votes is that it's to, as I said, lead and coordinate health services to promote the health of all people. So from a policy perspective as well as, so you will see a lot of the performance indicators, in fact, is to do with the health framework and the guiding principles and policies of the systems of hospitals and of the healthcare professionals. Resources divided amongst is the 6 budget programs. So we'll look into administration, national health insurance, communicable and non-communicable diseases, primary healthcare, hospital systems in the health system, governance, and human resources. The conditional grants we have counted for 90%. Or 173.9 billion of the department's budget. And the included under the Department of Health are a number of public entities, which, as I said, we'll look into. Next slide, please. Just want to quickly show the budget's trajectory. This is looking at the average trend and growth, which we'll dissect later. Next slide, please. But this is what ultimately, next slide, please. This is ultimately what I want to show you, Honorable Chair, is that as you can see over the past few years, by program dissection is that the under expenditure for the 23-24 financial year has indeed reduced to a slither. And that little bit of under expenditure, fret not, is just good practice, and we agree with it as Financial and Fiscal Commission that it's for some of the cost containments and at the margins though and it does not and should not affect the overall productivity of expenditure or efficiency of the expenditure. And looking forward is that, of course, noting that the budget's trajectories and movements is, as I said, the fiscal constraints at the macro level is that it has been reduced slightly over the past few years. And the COE reported spending of 93.5%, and that is a pretty good, healthy margin. The spending rate for goods and services is at 87.4%, but it's still remember that when we say at the national level, most of it again is to do, or most of its mandates and frame. It's about framework and policies. So in the actual sense, it's acceptable that the goods and services is within the range of the budget, and then overspending slightly on the capital assets of 42 million is it's a healthy trade-off for that element of investments. Next slide, please. The program specifically, we look at the communicable and non-communicable diseases program, accounts for the largest share. This is one fact. Over the 2024 MTF, though, National Health Insurance Program is projected to decline by 2.4%, and other movements across the different programs. Though it's not just, one should note that it's not just always bad if the program is to reduce, if the performance and the deliverables of the program has been shifted, and especially to do with national health insurance. One of the things that we notice since its start of this, or the conception of the national health insurance program, has been that it's been evolving and moving across different programs, even the conditional grants, which we'll go into. You will see that the scope and the structure and the composition of and components of the grants structure has been moving, and then with it, to do with the function shifts, and then it's also about the mending of the way that the grant is to be implemented, and so it does require a further. Just to note that a deeper analysis into the structure of these expenditures. Public health sector is very sensitive, though, we note here, to budgetary cuts, and is under pressure from high rates of medical inflation, as we have learned from the CPI decomposition. Next slide, please. And the COE, the earlier that we looked at with the healthy marginal containment, is to increase the budget by 5%. So that is around the average trend of the headline inflation. Goods and services shows an overall decline of 0.4%, but that is good in the sense that it's at least responsible, answerable to the fact that there was a slight under expenditure. Transfer and subsidies are projected to increase by 4.4% because most of the grants and transfers is implemented, and for health especially is, of course, national health, or the national grants, direct grants and indirect grants, are flowing through to the subnational spheres of government. Next slide, please. To compare between budgets, just to look at how have we fared in terms of budgets and budget planning from last year, that is the 2023 MTF, to this year's 2024 MTF. And we can see that there has indeed been a slight decrease in terms of the budgets and estimates that is for the Department of Health. And the point here ultimately is to substantiate again the fact that there has, at the macro level, there is of course the constraining fiscal space, but across different programs. And this is where we shall look also for the fact of the performance, is that different programs is faced with different changes to their budgets over time. So just looking at it is the administration, national health insurance, communicable diseases, those three programs is experiencing slight cuts, whereas other three, primary healthcare, hospital systems, and health system governance and human resources, are slight marginal of increase, resulting, however, as I said, the overall fiscal space for health and for budget injections is decreasing slightly. Let me hand over now to Sabelo and Gianni to take over the rest of the presentation with your permission. Thank you, Chair.
Thank you very much, Jen, and good morning to the Chair and honorable members present and all other officials present in the platform. I'm Sabelo Mthandatho. I'll take you through the non-financial performance.
Okay, can you do like the other colleagues have done during their presentation? We saw their faces. We haven't seen yours.
Oh, okay. Sorry for that. Yes. Okay. Thank you very much for that. I must apologize. Yes, with respect to the non-financial performance, what we have seen as we're undertaking this analysis is that the key points that we'll go through the non-financial performance, the targets, and how the department has performed in terms of achieving or not achieving those targets. But I think key thing that we need to note here is that the department has overachieved quite a number of these indicators and targets that it had set itself. But in some instances, there's few instances where there's been underachievement of the targets that were set for the period. And the other thing that I think we need to note here is that in some instances, we've seen that the department has set targets which are lower than the targets it had obtained the previous year. And then it as a result, maybe achieves or achieved more than the targets that were set. But that has to be noted again, that in some instances, these targets that were set appear to be lower than they were in the previous year. Then maybe that's the thing that the committee members should interrogate. Given that, for example, the chair has also indicated that the department has done well with respect to the audit because it has achieved unqualified audit and it has improved from the previous year. And then furthermore here, for example, some indicators that we have chosen, for example, you look at the number of invoices paid within 30 days that it has set itself to deliver everything, to pay every invoice within or less than 30 days, which in some cases were not achieved because of a number of reasons. For example, the late information submitted, the late delivery of goods and services, the dispute of invoices. And we think that those are things that maybe there must be some improvement. There's one other issue that we thought that we need to highlight here, which is one of the critical issues. For example, if you visit our annual submission for this year, it has a section or a chapter that deals with the medical legal claims, which is an issue that we strongly believe as a commission that it has to be addressed. But here, for example, is one of the indicators that was set here, and the department had set that target to finalize the bill that speaks to that medical legal claims for 2023-24, but this hasn't happened. And then it is still in the draft form because it's sitting with the Minister of Justice as we speak. Those are a few things. For example, the one that I related to where the targets were set lower than the previous result that we achieved in the previous year. For example, the number of health promotion messages broadcasted on social media. The department has set to achieve, slide 19, please, has set to achieve 100 of those, and then it has achieved 738. But again, that 100, if you look at it, is even less than the target that was set for the previous year, 2022-23, the target that was achieved. Then that's why we're saying here there's overachievement, which is commendable, but it is key to note that the target that was set was lower than the previous year's delivery. Okay, going to slide 20. Again, we made an example. We said the department has overachieved a number of those indicators. For example, there, indicator number 1 speaks to total number of parcels delivered to pick-up points from the Central Chronic Medication Dispensing and Distribution Program. You could see that the target was 5 million, and then the department overachieved that to over 9 million, which is commendable. Okay, going now to slide 21. We've highlighted a number of indicators and targets. For example, we said a number of people started TB treatment. The target there that was set was underachieved because the achievement was about 80%. And then here again, there are challenges that have been highlighted, of which we think the department has to deal with those challenges because treating TB is very important. For example, those challenges, they include transport-related challenges, which we believe that those has to be attended to by department. On slide 22, there are a number of indicators, but if we concentrate on the last one on that table, which is the number of community outreach services to household, you can see the target has slightly been missed. But the main reason for that now is that many community health workers have left the program. And then now is where we see the impact of this budget cuts of fiscal consolidation on the actual delivery, because one of the reasons is due to budget cuts that those were underachieved. Okay, go to slide 24. Slide 24, there's a number of indicators, but we'll pick up maybe on the first indicator there, which speaks to the number of health facilities implementing the National Quality Improvement Program. And then you see again what happens there. There's been overachievement. So here what we're emphasizing is that with respect to non-performance, the department has set targets and it has overachieved those targets, but it's key to know that some of those targets were lower than what was achieved the previous year. That is the message that we're sending with that. Now going to contract grants performance, let's go to slide 26, for example. There, I'm not going to go through the description, what the program does, but it's key to note that these contract grants, as the previous presenters indicated, they take the largest part, about 90% of the budget. And now here, these ones that we have here, you can see they all speak to the national health insurance. Then key to note that there's two components of the NHI, initial health insurance grants, which is the direct component, indirect components. And then let's go to the next slide. Next slide again list some of these programs, which I believe that previous presenter has spoken to. But key to note that the district health program, and we've seen that it maybe it's about 40% or so of the budget goes to this program, and then it goes to this grant, and you could see that it has various key component, like your HIV component, TB component, malaria program component, etc. And then the other one is a statutory human resources and training development grant. Going to slide 29, when I would deal with the performance of this grant specifically. In summary, what we are seeing here is that the overall performance of commercial grants has been good, because now the spending is at 99.8%, which is close to 99%, which is a good spending. But key to note that there's a variation here. Some of the spending performance is around 97%, which is not that bad, and some is over 100%, which is 110%, for example, which again is commendable, but again is overspending. For example, here we're referring to 110% for the NHI in overall, and then the lowest one is National Tertiary Service Grant. But again, if we go deeper to the spending now within the components, for example, the district health grants, then we're trying to relate now what has been achieved vis-a-vis non-financial performance vis-a-vis the financial performance. This slide, in fact, if you compare these two graphs, it will show you that the first one on the spending performance for two Commonwealth districts, then it's around 96%, 99.6%. And then here, what we are noting is that now we're relating the non-financial performance to this performance. So you see that there was a 9% below the target, and then this is attributed again to the austerity measures. And then going to the NHI again, as we have said, there are various components of the NHI, but again, concentrating here on the personal service component, then you can see the performance. Looking at the graphs there, it has been very, very poor, and there's been zero spending. NHI service, personal service performance, the graph which is below, yeah, it shows 0-0. You see 0-0 for the past 2 years on the NHI personal service component, whereas there's a slight improvement on the NHI non-personal services, an improvement of 2%, whereas I think significant improvement you could see on the NHI, the health facility revite, which has increased from 21% and reached 100%, which is a good performance and a good improvement. The next slide shows the performance across different conditional grants. So you could see that though the performance is good, around 98% across all, but there are some underperformance. There are some provinces that have performed not that good compared to other provinces. For example, Gauteng has recorded the lowest average expenditure of 96.4%. And then key to note again that now if you look at Mpumalanga, the NHI, the greatest variation spending is with 81% in Mpumalanga, whereas Northern Cape has recorded 207, close to 208%. But again, going through the annual report provided by the department, you couldn't see the reasons why there are these variations over expenditure of over 200% and under expenditure again with respect to Mpumalanga. Those are the variations that we did see. And overspending performance again on the health facility revitalization grant, you could see it's at 103%. But again, here you've got variations. Here we're noting that the Free State and Northwest have reported expenditure of 113 and 122% respectively. And again, going through the annual report, we couldn't find the reasons why this has happened. Then that is one of the things, again, that we're flagging up. On that note, I think through you, Chair, allow me to hand over to Gianni to complete the presentation. Thank you very much.
Thank you very much, Sabelo, and good morning to the honourable members and the chairperson and officials on the platform. I'll take you through the remaining of the presentation. I just want to tender my sincere apologies for the slight mix-up with the slides earlier. I was facing some challenges on my side, and I hope it didn't create too much confusion. But thank you very much, Chairperson and honourable members. On the entities, just to highlight some of the key performance indicators, starting with the Council for Medical Schemes. In terms of governance interventions, there was a significant decline that can be noted. From 93 interventions in 2021 to 18 in 2023. So this signals quite a sharp deceleration and reduction in regulatory activity. To highlight in terms of policy, research and monitoring, the number of published research and supporting projects did increase in 2022-23, indicating some stronger emphasis on research policy, which is, of course, very important for evidence-based decision-making. So overall, although the Council has made some progress in some key performance areas, there may be still some risks in its ability to maintain oversight and regulate the industry. Moving to the National Health Laboratory Service, which provides pathology services for the majority of South Africans. Some key performance progress to note here is that in terms of response within 24 hours notice of outbreaks, the NHLS has achieved its target with a 100% success rate between 2020, 2021 and 2023-24. Furthermore, in terms of HIV viral load testing, the entities tested increase in 2023-24, reflecting some greater capacity for viral monitoring. And then also to note that despite some other improvements in the testing regarding the TB tests, we did see a decrease in performance to 91% from 91%, my apologies. Overall, the NHLS has maintained good turnaround times for essential health tests, and we have seen some performance improvement reflecting growing capacity. However, we do see this downward trends that could signal the need for some more targeted interventions. Moving on to the Office of Health Standards Compliance, which monitors and enforces compliance of the norms and standards that are prescribed by the Minister of Health. Here, in terms of performance, in terms of inspection specifically, there was an improvement from 10% in 2020-21 to approximately 20% in 2022-23, which indicates improved oversight. Resolution rates of low-risk compliance, as well as performance regarding use compliance, also saw significant improvements between 2020-21 and 2022-23, which indicates the increased capability of the entity in some key respects. So this enhanced regulation is really fundamental to achieving high standards of healthcare in the country as it prepares itself for major reforms in the sector, specifically in terms of NHI. Then we move on to the South African Health Products Regulatory. Here, this entity provides for the monitoring, evaluation, regulation, controlling of medicines, amongst many other health-related activities that are of public interest. Here, I think it's most important to note the percentage of new chemical entities finalized remains very strong at 100% over the past 2 years. And this indicates some efficiency in this key performance target. Furthermore, registration of generic medicines as well as clinical trial applications finalized have also seen improvements and show strong completion rates. And this is between 2020-21 and 2022-23 years of analysis. Unfortunately, there has been a steady decline in finalizing good manufacturing and warehouse practice licenses from a mere 59% in 2020 to only 22% in 2022-23. So this implies some difficulties which could ultimately impact the entire pharmaceutical supply chain if this downward trend continues. And then in terms of the Mines and Works Compensation Fund, this entity importantly collects levies from controlled mines, as well as compensates workers and dependents in this setting that suffer from occupational diseases, and reimburses workers for the loss of earnings related to TB performance. Key to note in this entity is that the number of certifications finalized decreased between 2021 and 2023. However, what is positive is that the benefits paid and the claims finalized did increase between 2020-21 and 2022-23, which does indicate some progress, as well as improved capacity in some key respects. Thus, while there are some concerns regarding the deceleration of certifications, the improvements in finalizing claims and paying benefits does signify some progress and efficiencies in that regard. And then the final entity that I'll take you through is the South African Medical Research Council. In terms of the council, which is mandated in terms of legislation to promote the improvement of health and quality of life of the population, specifically through research, development, and technology. We do see a notable digression in terms of key performance indicators, specifically between 2020-21 and 2021-22. However, there is a rebound which shows some improvement in 2022-23. So I think overall, despite disruptions in the research ecosystem that the entity faced, the recovery in the indicators do demonstrate the council's ability to adapt to some difficulties rather effectively. Chairperson and honourable members, I'll take you through some final concluding remarks and recommendations by the FFC. Some concluding remarks to note, as mentioned earlier in the beginning of the presentations, we see that health outcomes in South Africa do not reflect the relatively high proportion of health spending, and this is specifically in relation to low and middle income countries. In terms of health allocations, we see declining growth rates. And important to note that the medical legal claims, worker compensation demands, these remain some key challenges. In terms of financial mismanagement, mismanagement needs to be improved, as this could undermine the effective implementation of the NHI. And while expenditure performance in the 2023-24 financial years does show improvement, performance across programs, as noted earlier, is uneven. And then finally, direct conditional grants show high levels of expenditure performance relative to indirect grants. Finally, Chairperson and honourable members, the recommendations here emanate from the 2025-26 Division of Revenue from the FFC, and there are a few recommendations, firstly, that relate to inefficiency within the district health system, and then with respect to medico-legal claims. So with respect to inefficiency, the important point to note here is that allocative efficiency needs to be exercised through reprioritization, as the findings from the research show that there are a huge amount of inefficiencies in the district health system, and that efficiency over the years has indeed declined. So the recommendation here speaks to the need to improve the quality of healthcare within the system, and that technical efficiency of district hospitals should be monitored at the provincial level. Secondly, the second recommendation regarding inefficiency highlights the need for accountability mechanisms. These need to be strengthened to ensure that funds are optimally allocated. And in this respect, it would be useful if guidelines are provided on how management practices in district hospitals can be improved. And the third recommendation there speaks to the integration of health data. This is extremely important, and the recommendation is aimed at the Minister of Health in collaboration with the Ministry of Finance, as well as provincial members of the executive committees. So this integrated health data is necessary to improve monitoring and evaluation procedures. And then finally, the recommendations regarding to the medical legal claims. Here it is recommended that the Minister of Health prioritize the development of an integrated national information reporting system. And this should include the patient and doctors registries with real-time data. Secondly, under medical legal claims, the FFC recommends that there should be a uniform statistical reporting system, and this should be utilized to enhance the collection and analysis of data-related medical legal claims. Here, it's important to note that this can capture the reasons for a claim and the underlying clinical and treatment failures, which is important to understand to rectify the underlying issues that are bringing about medical legal claims and squeezing the budgets. And then lastly, the Provincial Departments of Health should budget for medical legal litigation, and the compensation payments related to this in accordance with normal budgeting practices. Here, budget forecasts should be based on actual expenditure settlement trends. And then finally, Chairperson and honourable members, the FFC recommends that the Minister of Health should commission an actuarial study into the viability of introducing what the FFC here proposes is a mandatory professional indemnity cover for all healthcare practitioners, including those in the public sector. I thank you very much, Chairperson and honourable members. I'll hand back over. Thank you.
Thank you very much. Very commendable presentation. One thing that I like about your presentation, it shows slide by slide what number, easy for the member to interact with your presentation, because they will simply refer to a particular slide that they would need some support to understand. May I recognize now honorable members by raising hands, and those who are unable to raise hands would indicate to me that I'm in a platform that is not able to raise, and those two hands have already come up. Can I get more hands from honorable members? If none, I'll take this round, and members, please come up with your hands. I have got 3 hands now. I'll take them in this order. Honorable Clark will be number 1, followed by Honorable Van Staden, and the last hand on the platform is that on Honorable Heko. I do
and myself, Doctor.
Honorable Dr. Tembegwayo has not muted herself. Maybe she's not able to raise her hand. Therefore, she will be number 4. And then the 5th hand will be that of Honorable Dr. Leroux. That's it. In that order, starting with Honorable Clark, Honorable Van Staden, Honorable Kleko, Honorable Dr. Susan, and Honorable Dr. Leroux, number 6. Thank you.
Thank you, Chairperson. Firstly, thank you very much for the very good presentation, and gives us a lot of insight and to understand exactly, where we are in terms of functionality. I would like to ask you, Chairperson, that the Minister really takes note of the recommendations that were made of the FFC today, in particularly medical legal claims and the impact it has on the budget in terms of our provinces and our provincial hospitals, because I think if we can get that right, you know, there would be a lot more funding to go around in order to take care of patients' care. I would like to ask the following questions. So the projected 5% increase over the 2024 MTEF for the compensation of employees, is this for current employees, or does it include the filling of vacancies for medical personnel? And then how does the NHI affect provincial health budgets, and what is the impact of this? And then regarding the primary healthcare contracting model, which was not achieved, how much was spent on this model, and what was the finding of the 9 CUPs? And then I just wanted to, I jotted this down. And, you know, we note that wasteful expenditure has been cut down a lot, and we commend that to the department because that's been a very big problem in previous years. But if I could also just get clarity of the programs that we have not been able, what were those programs that we have not been able to spend the full budgets on? And we also then call for the limited budget of departments to be spent by means of prioritizing necessary expenses related to key functions for the department first. So if that can also be taken into account, and if we at a later stage could discuss that even at the committee as well. I thank you, Chairperson.
Okay, thank you. Honorable Van Staden.
Thank you, Chairperson. My apologies for not using my video, but I think you read my message this morning according to network coverage. I hope you can hear me. Regarding the unqualified audit findings, the unqualified findings of the National Department for 23-24 with findings, and if we look at the Eastern Cape and Limpopo, who's got qualified audit reports with findings, can the FFC just elaborate a bit more what were the findings on the National Department as well as on the Eastern Cape and the Limpopo departments? My second question on slide 14, I just need some more clarity regarding the inventory of medical supplies, which is minus 9.5%, and the operating payments, which is minus 11.4%. And then my last question on slide 40, I concur with the recommendations of the FFC. I just want to know that they must explain to us what will the consequences be if these recommendations are not to be followed by the Minister or by the department. Thank you, Chairperson.
Okay, the third one is Honorable Eko.
Thank you, Honorable Chair. Good morning, honorable members and the delegation from FFC, as led by the board chair. Thank you very much for your presentation. Chair, my apologies for not showing up. My video is off because of the challenges of Vodacom. So I have broken that rule, Chair. My apologies. Then I have some comments and questions regarding the presentation. Chair, let me start by agreeing with FFC on the recommendations regarding the medical legal claims. I agree with them, and I think as a committee, we must campaign for those recommendations and monitor implementation thereof. Also, Chair, I think we still have a chance. We appreciate their presentation and recommendations regarding other entities and the department, because we are still to engage the department and its entities. So some of their observations and recommendations, we will use them when we engage those entities and the department. Coming to the issue of targets, I don't think, Chair, it is wise to lower the targets when one wants to overperform. I don't think the principles of being smart were considered. I think it's a no-no. It's a no-no for whoever is lowering targets, so that it's not an achievement. It's not overachievement. If you are going to lower, we need to follow up on that. We need to advise on that. We need to engage on that, so that the smart principles are used. Coming to my question, how does the FFC see these budget cuts affecting service delivery, Chair? That's my question to them. Also, what mechanisms are there for them to assess the impact of the department and its entities' performance on service delivery? Those are my questions, Chair. And also that, when was it a repeat, the issue of over expenditure and under expenditure, or it's just of the previous year? Because if it's been a practice, what is it that they have advised on regarding that? Because over expenditure and under expenditure is not a good practice, Chair. Also, how do they assess equity in health budget allocations, considering the socio-economic conditions across the provinces? Also that, Chair, how do they work with the provinces regarding what they have just advised us on? Can they share their experiences with regards to that? Thank you very much, Chair. I may come again if there is something that has just popped up. Thank you very much, Chair.
Unlikely you'll have time to come back. Honorable Dr. Thembekwayo.
Thank you, Chairperson, and thank you for the presentation by the Financial and Fiscal Commission. The first question would be based on, there's a statement that was reflecting on the presentation that says a number of people started TB treatment, but these patients with the TB end up not started on treatment due to various factors such as transport, social behavioral issues, lack of income and food. And I expected under maybe recommendations to the Department of Health to make them do programs that will help the people who are suffering from TB not to default on the TB treatment, and say, for an example, to advise them on services that says we bring the service to the people rather than people going very far or missing the treatment because of lack of finances, so that they can reach the services of being treated on TB. The second one, I also expected in detail maybe on how to advise the national, including the provincial healthcare, on how to bring the balance down on spending. What I mean is the spending should be balanced with the outcomes thereof, because somehow during the presentation they talked about high spending, but there was less outcomes on the spending patterns. And also to ask about, it's not asking, but it's about a comment to say, yes, we agree 100% with your recommendation that has been echoed by the other members of parliament, especially with regard to medical legal claims. It's a problem, and we have been discussing that, but you brought some recommendations that are very much valuable, and echoing also from other members of parliament to say we'd definitely like the Department of Health to take note thereof and implement the recommendations, and also implement the recommendations that speaks to real-time data, not the data that belongs to those years that cannot even help us in reaching what is positive that we are supposed to do. And also agree with the Department of Financial and Fiscal thing to say the Department of Health need to do a study on actual expenditure trends as they are happening in national and provincial. But the last question that I would like to ask is based on the NHI spending. I mean, there was a presentation on NHI spending in provinces. When and where does it start, this NHI spending? Because it has been recently signed into law. And where are this information coming from of the NHI spending? And here it's a talk about Mpumalanga and Northern Cape. Where in Mpumalanga and where in Northern Cape? What about other provinces? And how do you get this information? Is this the truth of this thing? When did the expenditure on NHI kick on? So definitely I would like to ask about that. Thank you, Chairperson, for this opportunity.
Thank you. Dr. Leroux.
Thank you, Chair. Can you see me okay? Thank you very much for the presentation and greetings to all the members. I just wanted to all the honourable members, should I say, just wanted to just get some clarification on some of the points of the presentation. Just firstly, around the, if we look at slide 11 and 13, the budget there, I just want to get clarity. I understand this is the budget for the National Department of Health. Then on page 14, that National Department of Health approximately is about 62 billion. On page 14, I'm not clear how this links in with the National Department of Health budget, because suddenly there are two items there, transfers and subsidies, which is 58 billion, provinces and municipalities, which is 56 billion. And both of so that's obviously must be another budget line, and it doesn't include what's being paid to the provinces. And so I just want to get clarity about the difference between those two budget items and how they work, and how much of is the 480 million, does that include those two amounts plus the 62 billion? So just a bit of clarity around that. Then I just wanted to also understand the slide 12 a bit better, the under and over expenditure. If that could just be clarified. So if I understand it correctly, previously there was significant, in 2021, there was significant under expenditure, for example, in primary health care. Are you now saying that from 2023, there's been hardly any under expenditure? There's actually been over expenditure, or am I misunderstanding that slide? So I can see communicable, non-communicable diseases, hospital systems and primary health care. Is that under expenditure or is that over expenditure? So if you could just clarify that for me. around that. And then just in terms of the debt servicing, again, there's a slide, slide 6 talks about fiscal slippage. And again, for us who are perhaps not financially financial experts, it'd be helpful to understand what you're saying there. I see on that slide there is a mention of debt service costs, and that's helpful to see, but that hasn't been reflected on the other tables. So if I could just get an understanding about that, sort of tables on 11 and 13 and 14, that there's no debt service costs reflected on those, and I just want to understand where that comes from. And then finally, just thank you for the recommendations. I think those are very helpful recommendations, and with the other honourable members, I agree that these we would like to see those implemented. I just wanted to get a sense from the Commission in terms of looking at the audit outcome trends on page 8, and we can see there, particularly the Northern Cape, KwaZulu-Natal, Eastern Cape, and Limpopo all have fairly adverse outcomes there. What are the recommendations around those provinces? I mean, some of those provinces have had problems for many, many years. Are there any recommendations around those provinces specifically that have performed poorly? Thank you very much.
Thank you very much, honourable members. Let me add my other ones here on this one. On the grants, you have indicated that you are happy to have close to 99% spent. Now, I'm not sure whether you are actually making projections, or at the third term, 99% spent on the grant will not be showing an over expenditure by the end of the fourth term, because I was hoping you are reporting as of this term, or maybe it's what we are actually reporting of last year's. We are not reporting on 2023, 2024. There's a statement that you made that you commend the department for spending less on the lower grades 1 to 6. Now, 1 to 6 grades, among others, is inclusive of porters, is including of cleaners. Now, will that not cause a problem if you are saying, Sabelo, that is making you comfortable to employ less and less and employ more of those higher grades, because they are doing evaluation, planning, and the monitoring of the department, as opposed to the real foot soldiers in the department? I think I must actually say the slide 30 on your presentation was actually a very bad slide, because it shows every province above 50%, but we are talking to 85%, 75%. It does not show, because almost all those provinces are sitting at close to 100. So your bar graph was really not showing well in terms of what you were trying to explain as differences between this province and that province. That bar graph was really not helpful in actually seeing what you were saying there. I would wish to hear the comments of FFC with regards to your presentation on this issue of benefits and compensation that is going on, because you probably might be aware that the compensation is for the lung diseases only that comes from this department. Any other injury, be it in the foot or a head, gets done elsewhere. How would you look into that situation, and what is your maybe comments in that regard? The last one is also to support what my colleagues have said with regards to the recommendations, but wanted just to tease off one that talks about the actual study, the actual science that study. What would be the benefit of doing that study to show the level of what the department will pay on each category of a healthcare worker through the medical legal? I did not understand. While we support the recommendations, I just need a bit of explanation of that part in that regard. Now, back to you, FFC.
Sorry, Chair.
Yes.
Mr. Mutubatsi's hand is up. Thank you.
Now, may I have Mutubasi changing that? Well, I saw that hand. I did not recognize, because the icon is not showing who that member is. I thought it was a member of public who would like to be engaged, can that gadget be changed into the proper name that is recorded in our please? If that is what I see on the platform, I thought you was a member of public who's allowed to attend our meetings but not allowed to ask questions. Are you able to to rename your gadget? Okay, that hand that is up is not able to speak, either to rename the gadget or speak, remains muted. Can then the FFC come with their responses, please?
No, thank you so much, Chairperson, for the engagement on the FFC's presentation and analysis of the health sector. I just want to address one question, and then I'll hand over to the researchers to give substantive answers and technical answers on some of the questions, Chair. What will be the consequence of the Minister of Health not implementing the recommendations of the Financial and Fiscal Commission? The recommendations of the Financial and Fiscal Commission chair and members are quite clear, and they are very cogent, and they address the key issues. The reality, members, is that there are inefficiencies in the current system that needs to be addressed. And through our recommendations, we are addressing those inefficiencies. There are inefficiencies in the district health system. Also, when it comes to value for money, when we look at the medical legal claims, we are not spending money on the right things. So we do not see value for money there. So those two recommendations then are quite clear. And for the Minister of Health then not to implement them, it will also signify a policy choice that he's able to make. But our recommendations will be to advocate that this recommendation will enhance the implementation of the National Healthcare Insurance going forward. If I can ask now the Head of Research, Chen, to lead the deliberations and the responses. Thanks.
Thank you, Chair, and thank you, Honourable Dr. Chair and Honourable members. Some very good questions on the, especially of the, I'm a technical person, so I like answering the technical questions. As in terms of the 5% COE for current employees or including the filling of the posts, is that so it's important to look at both, because for good reasons, to be fair to the department, is that of course the process of hiring and turnovers is a live activity, right? So when one plans for budgets, we ultimately many, and I don't know if the CFO of the department is here, would be, I think, glad to hear that. So when we look at the budget, we do, and that happens, say, on an annual basis, and or when it comes at least maybe during the adjustments, is that you're looking for the filling of the posts in terms of the funded post position of budgeting, meaning that the post is there and then you budget for it. And it's not quite necessarily able to say we only fund or we only say budget where there are warm bodies there, because warm bodies changes and the position sometimes can be vacant for various durations of that employment. So it is both. And I think this the reason why I do want to emphasize on this point is also will answer many of the other questions that I see honorable members are picking on, because understand that when financial monitors and these expenditure trends and analysis come in, one does have to think of it like it's a biopsy of a kind, right? And then, but you know that once we get the most accurate result at that point, the realities and the machinery of the department must carry on. And so I think it's an important fact to recognize and realize and appreciate, even though we are seeing these results and performances and we analyze them, the data, but still these are just biopsy results of a very live body of and mechanism of a department implementing and executing its duties on an ongoing basis. Effects of the national health insurance on the provincial health budget. This one to do ultimately with the implementation of the NHI program is that the NHI Act ultimately is attempting to converge in a market dynamic way that's separating two dual market system. And when one has to be obviously very careful in talking about that, in that it has to be done in a market conducive manner, market conducive manner, and it does happen. There is opportunity there, because in economics we always say where there are market gaps, or whenever there is a segment, a separation in the markets, there ought to be some business to be made. And when we say business, we do mean that there are benefits and with cost, because it wouldn't be benefits without cost, for both and for all participants in the markets. Let's put it, for example, at the moment, we know the separating equilibrium of the market demand for healthcare between private and public sector. For the private, of course, there is the trade-off of able to get more demand, right? Should it be pulled a little bit closer to the median, and then of course for the public, it's able to alleviate some of that pressure in terms of the budget. So it's those two. Now the NHI ultimately is trying to find that middle ground, and then as per FFC recommendations in the past, and then we're happy to also or we invite honorable chairman or chairners, but honorable members might be interested to read, is that we think that's gel, if you like, that glue, that bonding solution is as actually one honorable member mentioned it, it's a real-time data of both the registries of the patients on the demand side. We cannot lose track of that. And also the registry of the doctors. At the moment, even though our NHI has been in conception since 2012, even earlier, I've read somewhere from the HSRC research, but still today, the system is still not quite right there. All I need to prove is to ask the questions. Please, if I go to hospital A and then I've gotten some treatment, would I have to, or would I be able to just walk into hospital B tomorrow without having myself repeating everything that I've done in hospital A? And if the answer is not, then the NHI system is still not yet there. Primary healthcare contracting, how much it was spent on the model. This one it's a rolling budget, so it's a bit difficult to answer that, but one does have to look at all the way from the start of the program of the NHI or of the primary healthcare, and then just look at that expenditure trend. And as honorable members could see in at least in the past 3 or 4 years until now recently, in the latest financial year, there has been instances of quite a bit of under expenditure there, as that is at least what the data is showing us. Unqualified audits and the qualified audits of the provinces, and in specifically to those disclaimers, just to maybe explain, and of course this by no means an accountant in training, I'm more economist, but the ultimately disclaimer means that when when the Auditor General is asking for simple things, it's almost like asking for a receipt if there is an expenditure or that there is some spending that is being conducted. And then they ask for information, they call it the RFI, and then the department is just not able to provide them. And so they can't give an opinion effectively. And that is in some sense correctly so worse than other kinds of opinions, right? It's basically they are saying effectively that we cannot give you assurance that your books are even remotely close to the true reflection of the financial status of your department. That's effectively what a disclaimer is. And then the others, for example, qualified audit means that, yes, there is some information, but then...
Mr. Chen, please don't go there. Please don't go there. We know that part, please.
Apologies, Honorable Chair. Going to on the specifics of the program versus economic classification. So the transfers, the subcategories actually is underneath it, and those two program and economic classifications are the same. It should be the same, and it should be added up together to ultimately be the national department's total budget. The significance under expenditure is shown there. So the 0 line means the budget, and then the over or under that graph it means over expenditure or under expenditure. Debt service cost, just to elevate up to the point is that the debt service cost is at the fiscal framework level, meaning that it's the first direct charge on the fiscus, not for the department specifically. And the reason why that is important is because that the debt service cost is the first direct charge. As I said, it means that before the Treasury is able to say how much should go to Department A, B, C, D, and F, G for whatever policy priorities, is that that already needs to be taken off our books. Because the debts and our creditors are already knocking at our doors, and as that we cannot default on those debt promises. And I've also said that about the audit outcome. Apologies again for that. Honorable Chair, on your specifically, and this is quite detailed, on that that grading of or the salary levels of the department's compositions of staff, it's not at this point easy because, as one can see, it's not divided or decomposed in terms of what programs that we are looking at for those the job gradings and job levels. So we're unfortunately not able to answer you with that unless we go by program and understanding and aligning the mandates of the program to the composition of the organizational structure for that program and aligning that to the cost to function. The bar graph of provinces are not showing exactly clearly. We take note of that, and we shall improve on that. And we also note the actual studies. Honorable Chair and members, from my side, I think the last comments I'd like to just say is that that one does need to start asking the department for the outcome of that system. The reason why, again, as I've emphasized over many times, is that the health system, especially the just healthcare system for our people, it's a system that needs to basically respond wherever and whenever there is a need that arises. When someone is hurt, you do need the health system must be able to respond to it. And it does create a very big barriers to information, to access, and to be able to responsively accommodate or treat that patient if we don't have a system that is able to basically track that activity, track that supply, historical, its patient history, basically, to track that patient in some form or manner. And that is supposed to be the NHI. And so after this many years, without that system, this separating equilibrium is not able to converge. And that every year and continually so, it's only going to solidify, unfortunately, the separation and the dual market structure of and letting many of our less people that are less able to afford healthcare systems and quality healthcare right there between those two markets. Honorable Chair, members, I hope that let me just for 1 second to allow my colleagues if they have anything else to add. Thank you, Chair.
Sabelo, Gianni, comments, please.
Thank you, Chairperson. Thank you to the honourable members and the chairperson of the committee for the questions. I just want to elaborate a little bit on the question regarding the consequences if the recommendations are not followed. So following on what our chairperson has said, more specifically, if we look at medical legal claims, without implementing these recommendations, as the chairperson highlighted, which are aimed to ultimately improve service delivery in the healthcare sector and improving efficiency, without implementing the FFC's recommendations on medical legal claims and addressing the root causes of the medical legal claims, these claims are likely to continue. And if they continue, they'll continue to crowd out the health budget, which will have adverse outcomes on service delivery. So the risk here is that it could have a negative reinforcing effect, where the rise in the claims lead to increased pressures on the health system, which lead to further problems in the quality of care, leading to further medical legal claims. So this is a significant issue that needs to be addressed, and the FFC's recommendations tries to navigate the core problems of this and provide some useful advice into how to tackle this significant issue. And then on the recommendations regarding the inefficiency in the district health system, I think important to note here is just that allocative efficiency, which the recommendation speaks to, or more broadly, productivity in the hospital system, most simply refers to how inputs in the hospital production process leads to outputs. So critical inputs here, we're referring to, say, the number of doctors, the number of nurses, budgets, hospital beds, and so forth. And the outputs would then be measured from the number of inpatients and outpatients that receive treatment, the number of preventative screening tests, etc. So these recommendations really speak to the fact that inefficiencies are occurring across most district hospitals in the sense that these critical inputs are not translating to outputs. So it's important to understand here, and what the recommendations are based on is the findings on what actually drives these inefficiencies, such as the lack of nurses or medical staff relative to the uninsured population, and the lack of preventative health care. So without implementing this recommendation, the recommendation emphasizes the need to measure these inefficiency levels and to monitor them. So without doing that, it would become very difficult to keep track of the improvements and ultimately how to improve service delivery in the sector. And I think, again, we've already touched on the need to the integration of health data. So I won't say anything further on that. Thank you, Chairperson, and thank you, honourable members.
Okay, thank you very much. Thank you very much, Chairperson. Let me just reflect to one or two of the issues that were raised. The first one would be the issue that was raised by Honorable Clark on the model that was not achieved, whether do you have an idea how much was allocated to it and how much was spent and what are the reasons therefore? Then unfortunately at this moment, because we are relying much on what is provided, what is contained in the annual report, then information that we got is at the program level and it's not that deep to project levels where we'll be in a position to share with honorable members how much on that program has been spent already or how much was not spent on program level. Then unfortunately, we don't have such information, but that's what was reported, that there was that underachievement, and then we're also concerned about that. The other issue that maybe that was raised by Honorable Clerk was with respect to the targets that were not met or the setting of the targets that we, at the moment where we are sitting, because we believe that these targets, yearly targets, they are from the APPs of the departments, then probably departments would be in a position if honorable members could ask them, because I believe that maybe in some instances, the reason why these departments or Department of Health has set some targets at a lower level than the previous year, maybe could be as a result of the austerity measures or reduced budgets. But again, I think further engagements with the department could share some light on these issues. The other issue probably is with the TB issue that was raised by Dr. Tembegayo. Yes, Dr. Tembegayo, it is a concern even from the Commission side that this important program, the TB program, is underperforming, is not able to achieve what has been said or was said to be a target due to some of the reasons that we are of the view that could be addressed. For example, I think you are spot on to say, for example, if there are challenges with transporting those people who are supposed to receive TB treatment, and then a plan should be done, is either to have a center, a nearby center where these people, this patient could be able to access such medication and start the medication as early as possible, for example, and again, to develop some campaigns and plans to change behaviors of people, because maybe they don't understand the seriousness of this and implications of this to the department. Then such plans and such programs could improve the uptake of the TB utilization, medication utilization, and I think those are just few points that I wanted to reflect on. Thank you very much.
Yeah. May I add one? Hold on, Sabelo. May I add just one? There's one member that has just sent one to me here, and then maybe we think we should just have it here as also being answered. But we can't go beyond 11 minutes past 11, so that we move to other places. This member is asking if you have been able to advise the Department of Health regarding the improving the validity and the reliability of the information in the annual report. If you have or have not, or what is your view on that plan? And then Sabelo will add on. Please, you have only 4 minutes to finish your presentation so that we move to another presentation. Thank you.
Sorry, but Chair, I didn't hear well on the question on NHI and the provinces. It's a question that I
adding on. I cut them in the middle of that. I was adding the other question that you put on place. They didn't say they are finished. You raised me a question. I'm adding on them on while they are answering.
Okay. Thank you.
Okay, Sabelo, do you have a comment on the the APP, the targets, the question?
Yes, Chair. On the question that has been raised by the Honorable Chair, we just take information as we receive it from the annual reports or the annual report from department. We use that information, so we didn't go to the extent of validating whether that information is reliable, because we just assumed that because it's from the annual report, which is an audited document, then we just took it as it is, and then we interrogated, we analyzed it. So we didn't go deeper in terms of verifying the validity of such information. Thank you.
Can you then comment on NHI?
Okay, NHI, Chen, NHI or Gianni?
Yes, Honorable Chair, I think I hope I did address that on the NHI is that ultimately we do need to just see that system up and running of the NHI, because it has come to a point now where the NHI grants, the funding, and it's all there effectively in terms of funding. And we have even redesigned and over and over the structure of funding, as you can see, as we can see in terms of the direct grants as well. We even went through the phase of indirect grants. There have been, of course, the pilot studies that have been conducted. The ultimate issue, though, however, is that's a system of registries as from the FFC perspective, as we made in terms of our recommendation, Honorable Chair. We'll be happy to, if there is more information that the department can or share with the FFC, then we're happy to do that analysis to look further into the performance and outcomes of that, of implementation of the NHI. I hope that answers, Honorable Chair.
Okay. Okay, then that brings us to the end of this presentation. I'm glad that some of the members who have since joined from the department have been able to catch this last part, especially some of the things that will engage with them in recommendations. Unfortunately, honorable members, we will not be able to go on a second round because of the intense program that we have today. We might have to do as Honorable Tembekwaya did, send some of them on the site, then we forward it to them, or maybe get a chance to them to answer on the platform. But with that, I would like to thank the Financial and Fiscal Commission presentation and some of the things that we have recommended, which will really assist us to share and discuss that with the department when we see them later in the week. Thank you very much. Honorable members, can you take a 5 minutes break, but don't log off while myself and Ms. Machalamba try to rearrange the day, how it looks like as we are tracing the Auditor-General. Thank you very much.
Thank you all for coming and for the good presentation.
Okay, good day once more. I learned that the AG has since logged in. We were trying to locate them here on the platform and you don't see them then. So we took a time just to get the members back. And in this 5 minutes, hope that members have just had a chance to just stand up and get out of the chair for a while and move around. This is what we should do regularly while we have these presentations. It's a long day, so just sitting like this is not going to be very healthy. Can we
Chair,
then?
Thank you, Chair, but can you give us at least the indication of our tea breaks and our lunch breaks and all those things, please?
Check the program. It's all written in the program now. Thank you very much. Can we get the AG to look into, if you have not received the program, you will look at it. It is there in our chat, the program. Can we get the AG to come in and make their presentation now? Thank you.
Good morning, Honorable Chair and Honorable members. May I please have confirmation that I am audible and the committee can see me?
Chair? Yes, we are audible. You can see you. Thank you.
Thank you so much. To the committee secretary, before I start, may I please add Ms. Mule-Tipe. She's the one that's going to be hearing this, the presentation. So please add her and give her the rights. Good morning once again. My name is Tabelom Sisinyani. I am the business unit leader from the Office of the AGSA, one of the units here in Pretoria. I am responsible for, amongst others, the health portfolio. So I would really want to greet the honorable and honorable members and the representatives of the department and entities. I think I saw some names I know on the participants. We really would want to thank the committee for this opportunity to come and share the audit outcomes of the National Department and its entities, as well as the sector at large, which includes the Provincial Departments of Health. I am not alone with me. I am with Mrs. Neliswe Mhlongo. As I mentioned, that they'll just show their videos and wave. I think because the health sector is big, I think I have a big group of people. I'm just going to announce those that might participate with the committee through either presentation and questions or answering questions. I'm also with Ms. Mule-Tipe. She's the senior manager responsible for the National Department of Health and its entities. She's also supported by our health specialist, Dr. Mulepane. She is also based in the office here, I see on the video. We also have Ms. Mbonso Chauke, who is the information system auditor, who helps with the auditing of this information system within the sector at large. We should also have Mr. Stembiso, who assists us with the infrastructure. Honorable Chair and members, there are also other members from the AGSA that are in the background, the managers that support the team. So I was only introducing those that might interact with the committee today, so either through presentation or through responding to questions. Honorable Chair and members, ours is a very long presentation. I really hope that the committee does indulge us. Every time we present the health, because we look at the outcomes of the National Department and its entities, and we also include the outcomes of the sector, usually our presentations are long. So I'm really hoping that we will try to summarize as best as possible, but it might take slightly longer, and we do really request your indulgence, honorable Chair and honorable members. So the presenters today, we also try to limit the presenters because the slides are a lot, but the main presenters are going to be Ms. Neliswe Mhlongo, Ms. Mule-Tipe, as well as Dr. Mulepane. They are going to be the main presenters. I'm just going to help with the opening as well as the taking some of the questions with the rest of the team. So I think we wanted to start with a bit of background, honorable Chair and members. Unfortunately, we were not able to meet the committee from an induction point of view What we were doing as the Office of the AGSA with the 7th Administration, we had a series of induction sessions, and for us it was important because we really wanted to set the foundation for the new committee with the information or the insights that we've been generating over the past years. I did see that there are some members that I'm familiar with from the previous administration, but we also did see that there are also new faces. But I think because we did not have an opportunity to do the induction, we will try cover some background where possible. So we do apologize if maybe we seem like we are taking a little bit longer. I think the other point I wanted to highlight is the fact that we also did not include the work on medical legal claims. This is because, Honorable Chair members, you would recall that in the joint meeting with SCOPA and the Standing Committee on Finance, we did come and then, and appropriations, we did come and present. So for the purpose of this presentation, we have excluded those outcomes. However, the information is available if the committee would like a copy as well. I think also maybe as before I also hand over to Nelisi, what I wanted to also highlight is what we're also covering from an induction perspective was also a reminder of the responsibilities of the AGSA, where we were indicating the fact that our responsibilities stem from Section 188 of the Chapter 9 of the Constitution, as well as Section 20 of the Public Audit Act. And our responsibility, we mainly look at 3 areas when we are auditing across the departments and the entities. We look at the audit of the annual financial statements that are presented annually to us on the 31st of May. We also look at the audit of the predetermined objectives. This is where the auditee will give us the annual performance plan as well as the annual performance report. So we audit that. We also then audit the compliance with laws and regulations, mainly the ones that relate to financial management. We do have certain instances where we look at other acts, but mainly we focus on the ones that relate to financial management. We also perform what we call discretionary audits. I think we do that a lot at health, and this is in instances where we note a specific area where we feel we need to do a deep dive, or when there is a directive either from presidency for us to look at a specific section. A good example in the health sector is during the time of COVID-19, we were requested to look at some of the transactions during that time. So we were able to do that audit and release a special COVID report. So we also then look at other sections over and above the 3 main areas we look at, and we look at them depending on the need that is taking place. So you would recall, even at those who've been in the health sector for a while, we once also released, we used to release health sector reports on an annual basis. That has changed a bit, and we also once had a report on pharmaceuticals. So those will fall under what we call the discretionary audit. The last part that I want to highlight is around the amended powers that we receive, which is the material irregularities. These we received, I think it's 2019, and there are some few material irregularities you see in the presentation within the sector. So in the main, those are our main focus areas as the Office of the AGSA, and we are going to cover those areas in the presentation. So a lot of these areas are a reflection of what the Honorable Chair and members will find in the different audit reports of the departments. It's just that maybe the format might be slightly differently, but what we are doing today, we are sort of giving a little bit more detail on what these audit reports that are sitting in the annual reports of the department are indicating. So I think, Honorable Chair members, that was just my introduction remarks. I will hand over to my colleague, Nasuwa Mhlongo, who will then start off the presentation by covering the section on the performance report. She will then hand over to our health specialist who will cover the service delivery sections. And I think with this section, over the years, we've been focusing on specific areas, and she will cover the main areas that we covered in the current year, and then she'll then hand over to Mule, who will then look at the financial management side, and Nelly will just close off the presentation. Like I said, it's a little bit long, so we really are requesting the indulgence of the committee and the chair today. Over to you, Nelly Siwe.
Hold on, Ms. Masusinyane. We have received the
Chair.
presentation. The reason why we asked the presentation the day before is that you don't take us through the presentation word for word.
Okay.
You take it that we have read the presentation, and therefore your presentation must actually take that into consideration, and that we have a day finishing at 6:30 today with other presentation. So we don't have only AG to present. The report was given to us to read, and for you is not to take us word for word on that presentation, is to give highlights and move on into presentation so that you stick to your 40 minutes allocated. Okay.
Thank you, Honorable Chair. I think the presenters will take that and note the presentation read, and they will then summarize. We will really work hard to aim for the 40 minutes. Thank you so much. Over to you, Nelisiwe.
Thank you so much, Tabelo. Good morning, Honorable Chair, honorable members of this committee, and all other colleagues on the call. I think Tabelo has already introduced me as Nelisiwe Mhlongo. Chair, without wasting any time, and I would really do try and summarize whatever we can summarize, but I want to start from this slide that we've been talking about as an office and audit office. I think we've recognized that as an audit office, there is so much that we can do in terms of what has been given in terms of our constitutional mandate. But we then as well recognize that there's a whole accountability or the ecosystem that exists within each organization or in government in general that needs to now start driving some of their key, responsibility to make sure that we see a good picture. I think our culture shift strategy has been such that we want to see the public sector moving towards doing good. And in us achieving the towards moving doing good, we actually are then saying that there needs to be key role players in the whole space who are supposed to do what they're supposed to do. And eventually we see the good culture of accountability, integrity, performance within the portfolio. Honorable Chair, I think in terms of the health portfolio, we've actually identified the critical ecosystem. We've actually named it from a patient right up until to parliament kind of accountability ecosystem to say the patient has a responsibility in terms of what they need to do together with the senior officials within the department or any entity within this portfolio and sector, to those who are charged with governance, leadership in terms of your DGs, in terms of your ministers and MECs, but right up until to the others, role players that are sitting in the oversight space, similarly to the committee that is here, Honorable Chair. But what we are saying as an audit office that will continue providing insight and use the insight to influence some of the areas where we can influence. And then where we are able to, that's where we'll start pulling the lever for amended mandate, which is then the enforcement. I'd like to quickly move on to the next slide, Honorable Chair, which even that one, I'm not going to go through it. We just have grouped the type of the ecosystem or the role players in terms of health, who are they and what are they responsible for. So I'm not going to go into detail with it. But then I'm taking you through one of our areas of audit, which is performance information. And we thought we need to start here, Honorable Chair, to then say, what is this portfolio and together with the sector and how they're achieving it? You will see throughout our presentation, Honorable Chair, we would reflect a bit about the portfolio, which is the National Department of Health, together with the entities that are sitting at national. And then at the bottom, we'll speak of the sector, which is made up of still of national department, but together with the other 9 provinces that are there within the sector. So that's how our presentation is hitting online. I think the 2 bar charts that are there, Honorable Chair, are just reflection of annual achievement. For the one that speaks to the portfolio, which we're saying is health entities, it's just reflecting the programs or the objectives that we have audited. So this is the achievement specifically limited to those. At the bottom one, which is the bar chart that talks to the sector, that one is specifically on the achievement of the MTSF. So it's only concentrated on the MTSF targets and how those departments have actually achieved them. But we just generally in this slide, Honorable Chair, we are just saying that we commend the department and their sector as well to a certain extent where they have achieved some of the MTSF indicators and target. We are bringing a 5-year picture. We do know that it is at the end of the previous administration, and we thought it's very critical that we actually reflect on that. We've also included OHSC specifically for this one because we do recognize the critical role that they play. The indicators that are there may not necessarily be that of the MTSF, but they are critical ones in terms of their achievement or not achievement. But I draw attention to those that were not achieved. And we're just highlighting the fact that the sector itself are in progress of implementing about 3 of those indicators, and about 16 of the targets and the indicators in the MTSF over the 5-year term have not been achieved. And we do know the impact of this overall in terms of service delivery. So we therefore urge the committee and then the sector as well to then say, if we move to the new administration, these are the things that needs to be focused on, and as well to make sure that in the next 5 years, there is proper action plans that are implemented to make sure that we start driving some of these key indicators that are sitting in the NTSF. I'd move to the next slide, Honorable Chair, and this is us now bringing insight onto the credibility of the performance reporting in terms of the annual performance plans and annual performance reports that were submitted by the entities and the departments. On this one, we are reflecting specifically on the portfolio of health, and we do commend CMS, OHSC, SAPRA, and MRC who have submitted those documents that are free from any material misstatement, meaning that whatever they submitted was useful, which is their plans, and as well their reports were actually reliable, and therefore the credibility of those two could be relied on. But then when it comes to the other 2 organizations that are within the portfolio, which is the National Department of Health, we continue seeing that they're having challenges in terms of reporting for the reliability of performance information. And this is mostly attributable to this the supporting evidence that is not supporting what have been reported as achieved in terms of their APP. And then we therefore urge the National Department of Health to start dealing with these issues that are there. Last year, we had more material misstatements in terms of those indicators. In the current year, we do have some, but they were not so much as what we had last year. But however, they continue having challenges in terms of this area. And then we've got the 2 other areas, which Mule, when he talks about regression and all of that, we will touch more on this. This previously CCOD, which is the Minds and Works. So we do know that Minds and Work has now been listed, and it got listed just 2 days before the start of the audit year, which we are auditing and reporting on. And because of that key decision that was made at that particular time, they could not prepare an annual performance plan, and therefore eventually could not report in terms of the performance. So we therefore are then saying that key decision has resulted in them having material misstatements in terms of them not being able to produce a credible performance report in their space. I'd move to the next slide, Honorable Chair. And an Honorable Chair, here we are bringing the picture of the sector and their credibility of performance information and how they've reported on it. Chair, this is one area we've been reporting on over the years. And over the years, we've seen material findings that have been identified into the sector. Specifically, where we are saying we have material limitation. Therefore, it means the auditors went and said, please provide us with evidence that supports this achievement. And there were no supporting evidence or documents or processes that could support that achievement. Therefore, that's where we were limited. And we are just saying we have seen a big shift in terms of what has happened in this sector. And one of that is the fact that in the current year, we do not have a province that has material limitation. However, there continue to be challenges in terms of how they report performance information, which still compromises the credibility of that information. And one of the critical things that we've been looking at is in terms of, if you look at Gauteng and Limpopo, they've got 2 programs where they really had pervasive findings. But we still need to deal with all the other issues that are within the portfolio that compromises that credibility. We commend the Western Cape, which has continued to remain clean in terms of not having any findings on performance information. However, there's a story to be told in terms of Free State, which Free State, for the first time in the previous year, they were the only other province other than Western Cape who have achieved no findings in terms of their performance information. And this is mainly attributable to some of the commitments that were there within the senior management of that province, some of the things that they were driving and instilling the culture and driving some of the daily controls, the monthly controls, and the reconciliation that are within the space, which is the recommendation we've been given. And that has resulted in them continue to maintain that status quo in terms of their programs that we audit, because even in the current year, they remain to have no finding. And we therefore say those best practices need to be rolled out throughout the sector to just make sure that the sector starts moving into the right direction. Some critical things that I've already spoken to that needs to be driven. One of them is oversight by the leadership of the sector, because therefore, if you've implemented a control, you've followed the process, but somebody intentional or unintentional does not even adhere to it, there needs to be a decisive action that is taken by the oversight leadership of this sector to make sure that corrective actions are done, and therefore we see a better picture in this area. Honorable Chair, the last area we looked at, which is the first time we were looking at this area, which we call completeness of relevant indicators in terms of the annual performance plans that are prepared by the departments and the entities. Critical in the current year, we only had one department, which is the Northern Cape, which did not include one relevant indicator that relates to the ideal status clinic. We do know that not including anything, or if something is not included in the AP, it's difficult to measure, to monitor, and as well, measure self-against performance and put corrective actions in terms of how we are performing. So therefore, not including some relevant indicator compromises the credibility and the ability to actually put corrective measures in that space. Honorable Chair, I'll just stop here with my presentation in terms of performance information. Dr. Molepane will take the next area, and I will come back a bit later. Thank you so much, Honorable Chair.
Thank you, Nelly Stewart. Good morning, Honorable Chair and honorable members of the committee. I hope I am audible. I will be presenting the service delivery slide, and I will start with the ideal clinic initiative. We all know that the SDG goal number 3 of the NDP and the 2019-2024 MTSF included the outcome relating to universal coverage, which meant that in the MTSF, there was a target set that 100% of primary healthcare facilities across the country must have attained or maintained the ideal clinic status by the 31st of March 2024. And if we look at the performance of the department according to their self-assessment on ideal clinic initiative, the department has not managed to meet the target of having all their facilities as ideal. But we have seen an improvement from the previous year, where the department has improved from 59% of their facility being ideal to 78% in the 2024. This a 19% increase. Next slide, please. We went on to inquire from the department, what is it that they've done to ensure that they get this improvement, and we were given the information around the interventions that the department has implemented that has yielded this improvement. And these were categorized around accountability, ownership, leadership, monitoring for compliance, and resourcing the ideal clinic initiative. So I'm not going to go into all of them, but I'm just going to touch a few, like issues of making sure that there are support systems in place. They made sure that there's ice cream champions, district permanent perfect teams, which help in supporting and leading the initiative, including the ideal clinic initiative as one of the key performance measures in the manager's performance contract also helped a lot. Having a quarterly review and discussing the progress of the ideal clinic initiative, to having checklists monitoring certain elements, and also making sure that items that talk to your non-negotiable vitals are there and they are procured and made available timelessly. Also including making sure that the budgeting is aligning to the ideal clinic quality improvement plans. The next slide, please. Honorable Chair, in terms of the audit that we conducted for the ideal clinic initiative, we did a follow-up audit on the 19 clinics that were audited in the previous cycle. And the major audit findings that we found were around 4 sections: infection prevention and control, measures around availability of medicine equipment and medical supplies, and human resource issues around the staffing, and also around infrastructure issues pertaining to the backup electrical generator. What we have put in bracket shows the provinces that had the finding for those elements that have been listed there. And if you look at the provinces that are highlighted in green, it shows that even though the finding was still identified in the current audit, but there has been an improvement when you look at the finding from the previous year. The root causes for this finding included a number of issues from infrastructure design that is not catering for the hand hygiene, to issues around lapsing of contract management that led to unavailability of medical supplies, the culture of compliance in the staff not being entrenched, and issues around filling of posts that is affected by the budget constraints. I just want to talk about the impact of this audit finding. So if you do not have hand hygiene facilities, or you are not adhering to the cleaning schedule, this has a negative impact on infection prevention and control measures. Non-availability of equipment have a negative impact on management of patients, which can also have poor health outcomes. If there is poor stock control system and management of your stock, then you have a risk of either stock out of medicines that are fast moving, or overstocking that might lead to expire of medicines. And also, if you don't have emergency trolleys that are constantly refilled with the appropriate stock, that means the facility will not have the preparedness to respond to an emergency when it arrives. And that will lead to poor health outcomes that also can lead to loss of lives. A shortage of staff increase the workload, affect staff morale, and may increase patient waiting time, the quality of healthcare, and the patient experience of care. If there is lack of backup electricity, that means there will be disruption of service during the load shedding. Next slide, please. We then did another focus area, which is the Ideal Hospital Initiative, and this was a new focus area. So this Ideal Hospital Initiative, we all know that it aims to improve the quality of healthcare services in the hospital. Before going into our scope and our findings, I just want to touch on the observation that we made. If you look at the 2019-2024 MTSF, it did not include the monitoring of Ideal Hospital Initiative. It mainly focused on the Ideal Clinic Initiative. And noted that 2 of the 9 provinces took the initiative of including the Ideal Hospital Success Rate Indicator in the 2023-2024 Annual Performance Plan to formally report and monitor implementation of the Ideal Hospital Initiative. And this province were the Free State and Gauteng. And according to the Ideal Clinic Hospital Monitoring System, 11% of the district hospitals attained or maintained the Ideal Hospital status in the 2023-24 financial year based on their self-assessment. But what we've seen is those 2 provinces that included the indicator in the FEP fared better than the other provinces. We see Free State having 20% and Gauteng 75%, as opposed to the average of 11%. So in terms of the scope of work that we did around the Ideal Hospital Initiative, we audited 20 district hospitals in the 9 provinces, and we audited the operating theatre and accident and emergency units, and we looked at the non-negotiable vital, and essential elements. In terms of the audit findings, then go to the next slide, please. Audit findings, root cause, and the impact, they were more or less similar to the ones in the Ideal Clinic. So I will not go into them. What I just want to focus on under the impact is we had a hospital that did not have an operating theatre for 27 years. That meant the patients that are in need of a surgical procedure will need to be transferred to the next hospital, which was 169 kilometers away. That in itself, we can see how that can affect the health outcomes of the patient and how the community that is being serviced by that hospital is not accessing the theatre services. Next slide, please. The other focus area that we looked into was the health sector information system audit. And we know that according to the strategic plan and the MTSF, the focus was around robust and effective health information system that needs to assist in automating the business processes and improving the decision-making process. So here we assessed the progress in terms of the implementation of the National Digital Health Strategy that is supposed to help with implementation of appropriate technology to enable a service delivery. And we also assessed implementation and usage of service delivery, technology, systems, and infrastructure. We looked at ideal clinics and ideal hospitals. And the first part was to look at the National Digital Health Strategy in terms of how well implemented it is. And we know that this strategy is supposed to help in strengthening the digital health governance structures, creating a robust integrated platform for development of information systems. And it deals mainly with around the scalability, replicability, interoperability, and security and accessibility of this information system. What we found was the NDOH has not fully implemented this strategy. It is still in progress. The provinces have no clear plan on how to roll out this technology to support and enable the service delivery. When we look at systems like RX Solution Pharmaceutical Management System, which is a system that is supposed to help the department in terms of managing electronically the inventory, the ordering, ensuring that stock is ordered on time and stock is monitored, the movement thereof, so that we do not get to the stock out. And if you remember very well, in the ideal clinic and ideal hospital, we had a finding on poor stock management. And you can see how the link of having a solution that is not fully implemented, how already it's impacting on the service delivery. So what we found was the dispensing module for this RX solution was not implemented or used in other provinces, whilst in other provinces was not used to its entirety. 16 of the 18 hospitals that we audited had the system, except that the Western Cape was using a different system. But the system itself also had some limitations, like it did not have the stock reorder triggers. It's not allowing the health professional to capture the expiry date, in exactly the date and the month and the year, but it only allowed the month and the year to be captured. That meant there's a risk of missing expired medication. When we look at the health patient registration system, which is supposed to assist in making sure that the user of the service that has got a unique identification number.
Ms. Your presenters are not indicative that we have a presentation that they are reading word for word and they are expanding on each and every point. You are not going to finish, ma'am, if you do it this way. That part we have seen. But over and above presenting what we have, you go and expand so much on each point, you are not going to make it.
I'll try and summarize, Honorable Chair. So basically, on this slide is just to raise the issue of the system not being fully implemented by the Department of Health. We also have the connectivity issues that make it difficult for the implementation and of the system. Can we go to the next slide, please? So the root causes is around consequence management, lack of governance structure, and we just have impact that I talked to around the issue of this technology not being fit to support the service delivery platform, and issues around if the system are not fully implemented, the department will go into the manual mode, which is not working for the department in terms of control. And also, we have looked at the fact that these systems are not talking to each other, they're not integrated. The interoperability is not well in place, and it hinders the implementation of the strategy. And connectivity issues that we have identified make it difficult for the implementation of this system. Can you move to the infrastructure slide? So we also audited the infrastructure, and we all know, as we know, Honorable Chair, that infrastructure is critical for ideal hospital and ideal clinic, because an ideal facility is supposed to have good infrastructure. So as we have seen, we audited projects that are being funded by the Health Revitalization Grant, and we have seen that 92% of these projects have a delay in completion. Most of them have been delayed over 37 months, which is a 3-year. We have issues around the cost findings around this project. 44% incurred more than budgeted because they had to extend the time and increase the cost of the project. There were also issues around poor quality issues, and also affecting compliance with the Office of the Occupational Health and Safety requirements. But if you look at the table below, it shows you in terms of the project life cycle where the problems are at. And you can see that there's a lot of findings for the project implementation and project management. And all these are impacting on the service delivery in terms of these projects that are delayed in terms of completion and in terms of commissioning, denies the community access to that facility, and those community will have to access the facility in the neighboring community. And there's also existing risk of vandalism of those completed projects if there is a delay in commissioning. And all those things we also talked to around the causes that make completion and commissioning delayed. And I'm not going to go into the causes and the actions that we talked to. I just want us to look at the examples of these 2 examples of these infrastructure challenges that we have identified. In the case of housing health, if we look at the Randfontein Community Health Sector, which was not completed, had a delay of 4 years. The project has not been completed. The department has spent 152 million on the infrastructure, and we have issued a MI notification in July. And there is causes around payment, non-payment of contractors and non-contractors. But the impact of this is that there's 152 million that has been spent. There's no facility that is completed for use by the community. That means other facilities are going to be overcrowded because this community will use them. With the Free State Health, we have an example of the Mansupa TB facility, wherein there was a delay in commissioning. The project was completed 3 years down the line. The commissioning has not happened. 2023, we saw a completed refurbished facility. When we returned in 2024, that same facility was now vandalized. You can see the picture on the right bottom that shows the vandalism that happened to those facilities. And this is around issues around safeguarding of the facility to avoid vandalism. Coordination between the infrastructure and the end user to ensure that the requirements are met. In this instance, there was no mortuary, and the end user would not utilize the facility, and that opened up the theft and vandalism. So in this instance, we don't have a dedicated multi-represented TB facility for that for that district, and it also caused overcrowding. 29 million was incurred in refurbishing this facility. Now the facility is vandalized, and there's going to be additional need to refurbish again and add the mortuary. Honorable Chair, I'm going to hand over to Ms. Muletipe to take us through the next part of the presentation. Thank you.
Good afternoon or good morning to the Honorable Chair and members. I'll be taking us through financial reporting and compliance, which is the debits and credits relating to financial statements that were submitted by the portfolio as well as the sector. In terms of the slide that we're seeing now, we are seeing an overall improvement from the first year of administration to now. We commend SAPRA for having improved from being unqualified with findings to being unqualified with no findings, meaning that there were no findings for MRC, OHS, and SAPRA on their financial statements, on AOPO, as well as there were no findings related to compliance. The Mines and Works Compensation Fund, there is a regression which is attributed to the listing where they now had to comply with additional requirements as required by the PFMA. With regards to CMS, it remains unchanged and it's mostly attributed to consequence management, which I will later then touch to, relating to where they're designated as the entity. In this next slide, where we're reflecting on the overall sector performance, there we're also seeing an improvement, Honorable Chair and members, over the administration year, where we are seeing that Western Cape has continued submitting financial statements that were free of misstatement. There are still some gaps, some improvements that are needed with relating to the rest of the sector. We are seeing Limpopo having improved over the last where they had one qualification area. Our concern remains Eastern Cape, Free State, and Northwest, and Northern Cape, where Northern Cape has a couple more paragraphs than all the other provinces. With regards to the Northern Cape, though there are many, but it's somehow a slight improvement from the previous financial year. Our concern is mostly relating to compliance, where there are numerous findings that we are seeing that relates to the Northern Cape. If we move on to the irregular expenditure, here we are seeing it looks like it's a decrease, but it's mostly a decrease because we have not included NHLS. The audit is still outstanding at this point. We are yet to capture the amount of the annual irregular expenditure pertaining to the overall portfolio. What we are elevating on the portfolio is the CMS, because what is basically standing between CMS and a clean audit is the irregular expenditure, particularly the consequence management relating to the irregular expenditure. So if that is dealt with, then we are likely to see CMS move from being unqualified with findings to being a clean audit. Relating to the sector, there is a annual increase relating to irregular expenditure of just over 2 billion rands from the prior year to this year, mostly attributed to the prior contracts that were declared as irregular expenditure, where there is spending that continues to be on those specific contracts. There's some instances where payments are being made on the expired contracts, as well as goods and services being procured without following the competitive processes as required by the prescripts. When we are reflecting on consequence management relating to the portfolio, Honorable Chair, we are seeing that consequence management is an issue within the portfolio where the bulk of the amount is there's no consequence management. So here we're reflecting on the prior year's irregular expenditure, where we are saying that it hasn't been adequately dealt with in terms of proper investigations being closed and finalized, and also ensuring that people that have incurred these type of expenditure are held to account. We are seeing that for the NDOA, there's just over 50% of the amount. It's currently being investigated and awaiting condonement. And there's some instances where the investigation is still in progress. Again, NHLS is outstanding, which was the biggest contributor in the prior year. With the additional powers that we're given, I'll just keep this slide and just move on to this one. With the additional powers that we're given to us, Honorable Chair, as Ms. Musisinyane has previously indicated, we have raised some material irregularities where we have identified non-compliance with the Act. We've identified instances where there were issues relating to the procurement processes, resource management. And when we're talking to resource management, we're saying that there's no benefit that was derived from the cost that was incurred by the sector. And on interest and penalties, we're saying payments were made. However, payments were made late. As a result, the suppliers started charging interest, and which is the amounts that were paid and which could have been avoided. There's instances of harm to the public sector institutions. This is where we have raised the material irregularity to indicate that we have less healthcare professionals in the provinces than what is required to properly service the province. Some of the other material irregularities that we've raised relate to the misuse of material public resources. So these ones are mostly attributed to the underutilization of the resources that are entrusted to the public. So there's instances where there is equipment that has been purchased, but that equipment is not being utilized in the hospitals. And this is where we then raise these issues. And then the accounting officer is then following up on those particular issues. In terms of the impact or what we are seeing relating to these issues that we've raised, material irregularities we've raised, we are seeing the responsible officials being held to account in the one instance. There's instances where investigations have been instituted, contracts are and we are also seeing what we like internal controls and processes being implemented to ensure that there is prevention of the recurrence of the irregularities. In other instances, we have prevented financial loss from happening, and we've also recovered some monies within the sector itself. Additional to that, Honorable Chair and members, we have seen improvement in terms of the sector outcomes where we've seen, as was presented by the prior presenters, where we've seen improvement in terms of AOPO. It is as a result of the MI processes where we are seeing improvements in terms of performance information. There's instances where the neonatal, the high care unit, this was in Mpumalanga, which was not previously utilized. It is now being utilized as a result of the MI process that we have instituted in the provinces. Thank you.
Thank you, Honorable Chair. I just ask that you just allow us 3 to 5 minutes to just conclude the last part of our slide. So, Honorable Chair, I think we've taken the committee and yourself through, the performance, the service delivery, the audit outcome. And then here we are just trying to then summarize and bring back the message overall to then say, what is the key takeaway? And I think in the next year, as we are continuing with this current year, what is those areas that whether executive authority or this committee should focus on in terms of the portfolio in the sector? So we first start with the commitments and the recommendations that were given in the previous year. Similarly, we went through the process, gave recommendations, got commitments from management as well as the executive authority. So this slide reflects on how they've actually performed against some of those commitments. You would see on the left, there's 3 areas. We've got 2 or 3 colors. So you'd see the yellow colors. Those yellow colors that we are saying, look, we set them as do this. They went and implemented. However, those things are still in progress because it has not been fully effectively implemented. The red area, we're still saying areas of concern remain in this area, and therefore the portfolio as well as the sector need to continue focusing on it. Then the green areas is those things they've implemented.
Similarly to the status of implementation, where we are seeing that there's progress or there's something good they've done, we've reflected as such. This is just the key critical one. I'd like to then move on to the next slide, Honorable Chair. And then this slide now talks to now, what are the messages or what are we saying the portfolio must address? This is dealing specifically with the portfolio on those areas. And then 3 key things that needs to be implemented is developing action plans that have adequate or that are addressing the correct root causes by the national department and as well as the portfolio itself. Those action plans must be assured or must be provided assurance by internal audit, making sure that they continue to monitor what has been implemented within that and then report as such on it. And those must address, issues that are around compliance of findings. They must address financial management issues as well as performance management. So meaning the reporting part of the whole area. And it is critical that this must be done. We would recommend as well the continue of capacitating in the ICT space, specifically at National Department of Health, because therefore we are saying this is the area they need to continue doing. It was there in our recommendation in the previous year. We are saying that should continue being done. Another area is that of consequence management, CMS, Mines and Works, as well as National Department. Those areas, those 3 entities must deal with the consequence management in that area. In the next slide, Honorable Chair, we are dealing with actually now the recommendation that speaks to overall the sector. And one of the key areas is in the financial management. And similarly to what we've recommended for the portfolio, to say the action plans must address the correct root causes, and those ones should be implemented to make sure that the audit outcomes are improved, compliance, performance, as well as financial reporting. So those daily discipline of reviewing financials and all of that need to continue to happen. In terms of the service delivery, the ideal clinic and hospital, we are saying the national department, together with the sector, need to advocate or make sure that the indicator relating to ideal hospital is included in the annual performance plan so that it continues to be monitored and similarly has the same kind of uptake and promotion like the ideal clinic status. The infrastructure matters, those key critical areas that we need them to be addressed by the accounting officers in order to make sure that issues that are around infrastructure are adequately addressed. The last area for the sector, Honorable Chair, we are saying when it comes to information technology, it is a key lever that is sitting or it's supposed to enable some acceleration of service delivery in terms of this. We are saying this needs to be adequately monitored and looked at, especially the implementation of the digital health strategy. It is critical in making sure that we leave the professional or the expert within the field to focus on that while we leverage on what technology could do for the sector. So the key things and the fragmentation and the issues that are sitting there need to be adequately addressed. So these were the recommendation to the departments as well as the entities. On the last slide, Honorable Chair, here is our message now to the Portfolio Committee and the oversight rule that we recommend must be looked at. In the left, we speak of the performance information, the inclusion and the monitoring of key MTSF indicator and generally key service delivery indicator need to be done by the National Department, and the committee should ask management to continuously report on them. And where the achievement is not being done, corrective actions and plans must be brought into this committee to show how then they're making sure that they are making up for that. We spoke of the material irregularities, and this is another area we are recommending the committee to focus on in terms of dealing on how progress is being made in resolving some of those. Consequence management is being spoken to, and it's part of the process that the committee should oversight when management comes. And then the last area is the area where they are dealing with action plans and the key controls that are around the 3 areas of audit, the performance information, the compliance, as well as the financial management. A reminder again that those action plans they implement must address the correct root causes and must be adequately addressed, and it must have the right controls to make sure that continuously those controls are able to pick up something if something is wrong in the system. And therefore, this must be brought back to this committee as well, so that oversight is exercised on that. Honorable Chair, I do hope we try to save you a bit of time. We know that we have too much message, but this is the message we are carrying in terms of the 2023-2024 audit outcome. Thank you, Chair.
Thank you very much. Honorable members, ready to ask and get clarity on this, but they are strictly, they're clearly very focused. They actually indicate what is supposed to be done by development, what is also within our mandate. We may just have to ask clarity on those issues and move into us that. Let me recognize members coming in for clarity seeking questions, comments. This presentation was very detailed. And I don't see any member as yet. Honorable Clark has her hand up. That is the one we are going to have. And Honorable Van Staden, Honorable Dr. Tembekwayo, 3 in that order, please. Okay. Start, Honorable Clark. You have lunch time starting at 1. So inclusive of questions and responses. By 1, you should be wrapping up, really. Thank you very much. Start, Honorable Clark.
Chair, and thank you to the AG for a very good report. It really, as the committee, gives us a real good guidance as to what our jobs should be going forward. And Chair, I would recommend that we really have a committee meeting where we sit, that the department designs an actual strategy to ensure with timelines that we achieve what the AG asks us to achieve in terms of oversight. There's just a few questions I'd like to just ask. What do you think is the reason for the department's inability to provide reliable information for the actual achievements on the annual performance report? How big would you consider the impact of this on the department's ability to measure the progress towards meeting its core service delivery mandates? What do you think the reason of the OHSC only achieving 19.62% of its target? Then, regarding the following findings, basic services not delivered to the citizens timely or not delivered at all, lack of quality healthcare resulting to reduced life expectancy of the citizens, non-achievement of universal healthcare for South African citizens, and not meeting the NDP goals in promotion of health. These are things that have been highlighted time and time again, and there does not seem to be much improvement year on year. In fact, in many health facilities, healthcare has taken a nosedive. What do you think are the reasons for this, and how do we address them? Regarding the ideal clinic status and self-reporting by facilities, sorry about that. That always happens when I'm about to ask a question. Regarding the ideal clinic status and self-reporting facilities, what is the scope for fraud in this regard? I ask this because I've done oversight at many facilities that claims to have ideal status, but the conditions are horrendous. And we saw that this week when we did oversight at the Northwest. We were told that they had already have a clean bill of ideal clinics, yet there were many things that were wrong. So I noted that you noted that there were deficiencies on 92% of the 25 projects visited within the sector, that the majority of infrastructure delivery projects have been delayed and is of poor quality despite costing more than planned, and failure to maintain existing infrastructure. What is the department's reaction response when you bring this to their attention? And Chair, I also would like to know when a contract is done in terms of infrastructure contracts, are there penalty clauses added into those contracts? So when people don't finish these contracts on time, they are charged those penalty clauses. Then year after year, consequent management failures are highlighted with little that seems to be done in this regard. And that is something we have to ensure that we make sure that this happens as per the AG's report. Thank you, Chairperson.
Honorable members, may I request, if each and every one of us has got 8 questions, we are going to have 64 questions, and we do not have all the time. Just prioritize your top 5. The others we can ask some other time, really, so that we can allow. Otherwise, every member would like to go the way Honorable Clerk has gone, 8 questions. Please, let's limit it and say somebody else maybe is going to ask what is itchy and take the top 5 and move on. Next, Honorable Van Staden.
Thank you, Chair. I have 100 questions, but now I have a problem. No, don't worry, I won't do that. No, I think we as a committee must seriously give attention to the recommendations of Auditor-General. By the way, Auditor-General, thank you for your comprehensive report. I always said I love it when you come to this committee because when you spill all the beans. Chairperson, so we have to look at that recommendations and we must start manage it and implement it. The key root causes like lack of internal control and etc. is something which always comes up every year. AJ, I haven't seen anything about the medical legal claims, the amounts, etc., or hear about it, unless I've missed it. If I did, my apologies for that. And the irregular expenditure, Chairperson, regarding this department of 359 million is still a serious problem in this department. Regarding that matter, I think it's time that the provinces appear in front of this committee to come and account for what they also have contributed to that. And then the poor stock control and management of medicines, medical supplies, infrastructure, and limited human resources is a matter of great concern, and we must seriously intervene in this matter. So if I can just get clarity regarding the medical legal claims. Thank you, Chair.
Honorable Dr. Tembegwayo.
Thank you, Chair. I just want to say, yeah, definitely we had the most important information that we needed to hear from the Auditor General, and it will serve as our yardstick towards all the committees that will be coming to present. But I just want to find out, in Cape Times of yesterday, there was a statement on AG that seeks stricter rules for unpaid fees. And here you are advocating to say any public institution that failed to settle outstanding audit fees could have banks attached. That's very serious, and that would be very good to get those people to pay your office. But in health, we have non-compliance to either your recommendations, or especially on consequence management. And I would still say, like I asked before, do you have another stricter way, like you are suggesting here, for those public institutions that pay to that? Very strict. That will make everybody, because we can't afford every year. There's a presentation that has got problems from the National Department of Health and all its entities. But we go on as usual, business as usual, and we intended that for the 7th Parliament, business cannot be as usual. So we need a stricter way of making sure whatever recommendations that we make are supposed to be done. Chair, I think I'll have that question only. Thank you.
Thank you very much, Honorable Keko, and then there will be Honorable Leroux after that.
Thank you very much, Honorable Chair. Good morning to the team that has just made a presentation. And we thank them, Chair, very much for such a presentation that they have made. This presentation will enable us to engage the department and the entities that are yet to come. Chair, I just wanted to say to the first presenter that it's never too late. They can come through if you agree yourself and Vyokas, you are our leaders here for an induction. Most of us in the committee, I knew I think there's one who has been here, or two or three. We can benefit out of that induction. Coming to what I want to say, Chair, is that as we have got from FFC that some entities and departments tend to lower their targets during the planning phase, and I got it that it's their mandate to look at the APPs. Did they penalize or did they look at the targets set by various entities and departments so that they can advise them not to lower the targets? Also, Chair, on the issue of what they have just presented on issues of irregularity, irregular expenditure, non-compliance with the legislation, whatever, how do they view us as legislators? More so this committee on health, are we doing enough to improve performance of the department? How are they viewing us as a committee now? Or they are just saying we are not their area of concern, but I think we have something to do to improve the performance of the department, to lessen any disclaimer that can be there. Thank you very much, Chairperson.
Honorable Van Staden.
I think it was me, Chair. I still needed to answer.
So sorry, yes. Sorry, Honorable Dr. Leroux.
I'll have another bite, Chair. Thank you, but no.
sorry, I'm mistaken.
No problem, Chair. Can you see me? There, oh, I keep on bouncing on them. Thank you very much to the team for the Auditor-General for your report. You always do excellent work, and we appreciate the work that you do and your recommendations. I just have really one question specifically around the Ideal Clinic initiative. On page 10, you spoke about the sort of improvement from 2023 to 2024 from 59 to 78%, and I see that as a self-assessment. And so I'm just kind of trying to get a sense of, we know that self-assessment is not always the most accurate way to measure things. How do these self-assessments get verified? And are you able to say that you agree with these self-assessments or not? And I think just as a general comment for the committee, I think that it's good to have the Office of Health Standards Compliance. It's good to have these Ideal Clinic sort of checklists. But I think we always do need to interrogate: are these checklists really helpful for better healthcare? Does it really result in better outcomes on the ground? And I think that we continually need to make sure that this is the case. And so I have looked through some of those standards, and sometimes they are onerous and probably not helpful to healthcare delivery on the ground. So I think we do need to it's great that there is a standard and that we need to meet them, but I think that we need to continue to reinvestigate those. But that's my main question is how do we make sure that the self-assessment is an accurate self-assessment? Thank you very much.
Thank you very much. AG, when you get a report saying there's an assessment of this facility and that, are they actually able to indicate that their ideal clinic status is going to be at this level? Because there's a categories of bronze, silver, gold, and platinum. Now, in your reporting, there is no indication whether you found them wanting on any of these categories. It's just that ideal clinics was somebody who was found to be on the bronze this year, then they are encouraged to do better on this and that. So it's just a general statement that comes in from yourself. I'm glad the department is also here. We'll have to ask them on Friday, but I don't think it was realistic for them to say there'll be 100% ideal clinic realization. What category? Is it all bronze or all platinum? Unrealistic target. And therefore they are measured on that, and maybe you'd indicate whether you are measuring a 100% ideal clinic status realization, platinum status, or what is that issue, including the infrastructure. I don't know whether there was also an expectation that all clinics infrastructurally will have a backup electricity, 100%, all clinics. What one has been aware of is all hospitals should and must have generators. All community health care centers, CAC, should. Whether there was an expectation that all clinics should have it, we need to hear both from the AG and also from the department the other day on Friday. but maybe then you can just clarify. I just didn't know what is last late listing of mines and works compensation. Maybe I don't know this term very well. You can really assist me to understand what is that. Thank you very much. And please try and wrap up just before 1 o'clock so that members can really take a break. They haven't had a break for that long. Thank you.
Thank you so much, Honorable Chair and Honorable Members, for the questions. We do take note that there's a cutoff time that we're working towards. So we will try summarize as far as possible. I think let me start with the one request around the chair that said the honorable member that said they are still available for induction. Even us from the Office of the AGSA, we do not limit our engagements with the committee only at the session. We are open if the honorable chair and members at any given point in time have an appetite to engage with us. We do work through our stakeholder liaison manager, which is Sengwezo, who's based in Cape Town. The request can come through. I think ours is really to ensure that as far as possible and according to the work that we've done, we empower the committee in their oversight role. So we are available for that. We will take it direction from the committee. I think I'll also then close the one from Honorable Van Staden around the medical legal claims. Honorable member might have missed it in my opening remarks. Because we had engaged not so long ago in medical legal claims, we had thought that we are going to remove it in this presentation. However, if the committee wants information, we can submit that in writing. There is work that was done. It's just that for the purpose of the presentation, we've excluded it. So we do commit to send through in writing the work that we've done, or our observation of medical legal claims, and its ripple effect on the financial viability of the sector. So a very similar slide we did in the last session, just including the 2024 outcomes. That information is available. We can share with the committee. I am going to also respond around the question around the reason for the non-achievement, not the unreliable information. This is looking to the slide that we covered, which is mainly in slides 7 and 8. Some of the reasons that we have, I think when my colleague was presenting, if we look at the sector, they really do come a long way with their information that is supposed to support what's sitting in their annual performance report, the achievements. So I think from our side, we always take it back from a planning point of view. So from a planning point of view, the sector or the department and the sector would have a set around the table and set targets that they want to achieve on an annual basis. What we always communicate with the team is after setting that plan, it is important that the internal control environment, it's also geared up to meet the targets themselves. And therefore, so that at least there's already an enabler that's going to take us there. So over and above the setting of the targets, I think the sector needs to also then reassess their internal control environment, reassess the processes, the existing processes that they have, and rearrange where required to ensure that whatever activities that they will be doing within the 12 months, if it's an annual performance plan, it's going to support them and assist them into achieving the target. So we do know the fact that because of how the sector is set up, it meant that, for example, if we take a good example with Free State, that has a good story to tell around the reliability of the information. What they did at Free State is they knew the importance of the information that's going to sit in the annual report. It starts at the facility level. So what they then did is they then had awareness session and workshops to say from the official on the ground who is responsible for capturing information, whether it's on the daily registers or on the patient files. They need to understand the importance of getting the information accurate. They need to understand the importance of keeping the evidence, because whatever they are capturing at the point of delivering the service, it has a ripple effect on what the sector eventually reports in the annual performance report. So that's what we saw that is working in Free State. So everybody in the value chain of service delivery needs to understand the impact what they do on a day-to-day basis impact the overall numbers that will sit in the annual performance report. So that's what we then see, because then when that understanding is clear in everybody in the value chain, when they are then discharging their duties, when they're then completing those daily registers, when they are then completing those patient files, then when we then come and audit, then they will be able to reconcile up to what's going to sit in the annual performance report. So I do know that they also have, the sector has a system in place that also does weekly and monthly reconciliations. So that process of reconciling the information recorded is critical. The reviewing of the process is critical, so that at the end of the day, whatever is sitting in the annual performance report is supported by evidence on the ground. And then that then assists with the reliability of the information that we will see in the annual performance report. The impact we see is the fact that we do understand the fact that these achievements that are being reported inform how the department, the sector moves towards or where to put their efforts. So for example, we then say if there's errors in some of the targets they are reporting, the department, it can go both ways. If there's errors, for example, of overstating a specific achievement, the department or the sector might think they are doing well in that area and not maybe put effort. So therefore, that's why it's critical that that information is accurate, so that when the department reviews their performance on a quarterly basis, they will then know where to put the efforts to ensure that at the end of the day, they meet the service delivery targets. I do see as well, there was a question around some of the reasons of non-achievements. I think for the Honorable Committee, Chair and members, the information around non-achievement is usually found in the annual performance report, but specifically for the OHSC, our understanding was that the fact that they had a capacity issue as well. So they had set the targets of the number of inspections they are going to do. However, they struggle from a capacity point of view. So it then goes back to my point that I said, when the departments of interest set targets, they need to ensure that there is capacity that's going to help them to achieve the targets. Because unfortunately, we'll then at the end of the day, we report a non-achievement. But I think for the detail of maybe the breakdown of some of these challenges, I think the committee, when they do engage with the departments and entities, maybe they can then ask for a detail on what are these contributing factors to the capacity challenges that they are then alluding to. So when I then I'm gonna ask my colleagues to prepare themselves to talk to the infrastructure. I hope my colleague is joined online on how are the departments responding to the findings on infrastructure and whether those contracts have clauses. I think my colleagues from infrastructure, I'm telling them so that they can prepare. I'm also going to ask my colleague, Dr. Mulapede, to reflect on the question around the idle clinic, to say, is there a scope for fraud in the self-assessment, and how are this self-assessment verified? I think on our side, when we were looking at the idle clinic, with our starting point, I think it also comes to the point of the Honorable Chair, we started from the MTSF target that the sector had set for themselves, that they want to achieve 100% at the clinic. Therefore, it didn't take into account the categories of the bronze. The sector said themselves that they want to fully achieve on all of them. So from the engagements that we have, even with the minister, they did acknowledge that maybe the target was ambitious, and they do acknowledge that in the new cycle, they will then try to be more practical in setting that target. So that one, they already acknowledged that maybe it was too ambitious, but because the target was on 100% on everything else, we did not look to the different categories of bronze and. But also with the work that we do know the fact that the ADIL framework is detailed and it has a lot of sections. We only focus on sections that we know we have included in our slides, for example, like 12, that's around the infection prevention control, medicines, equipment, methods, and infrastructure. We did not look holistically the framework. So therefore, so our outcome, it can have an idea on whether the sector is assessing themselves correctly. However, I think the detail would then be sitting with the departments. What we also did which we did not include here, we also looked at what is the OHSC reporting around some of those facilities. I think the OHSC, when they present, maybe that conversation could also be had with OHSC to say, when we look at the adult clinics that we are reporting in the self-assessment, what is the OHSC sitting on the ground? I think both that information would really help the committee to have a bigger picture, a clearer picture on the adult clinics framework. But I think my colleague will still talk to them part around the scope of fraud. There was also a comment. I think I might have included, if I forgot something, consequence management. The honorable member is definitely correct. Consequence management is one of the areas that we've been raising over the years within the sector. There are some departments that we are starting to see progress, but really there's areas that they need to really strengthen as a sector, and it's about holding people accountable. We usually say consequence management should happen swiftly, because the longer it takes, the more difficult it becomes. So what you see when you look at some of those irregular expenditure balances that we see, some of them might come maybe from 10 years ago. And unfortunately, it's difficult for the entities, the departments, to then try hold people accountable when some of the people maybe have left and there's a big gap. So what we do recommend to the sector is, when a non-compliance occur or non-adherence or any other instance that requires consequence management, it needs to be dealt swiftly so that the matters are quickly closed. We do know the fact that some of these matters then involve a lot of other legal processes, and which also have some other delays, but we really still recommend that the matters are dealt swiftly so that the culture within the department then change immediately. Some of the material irregularities that, or what we've seen, I think I did here on what stricter rules can we apply. So the material irregularity process, which is, there are some MIs that are currently sitting in slide 26. Some of the levers we pull around trying to make sure that there is a change in culture within the sector. So when you look at the sector, currently slide 26, like my colleague presented, there are some of the MIs, but I think I would draw the attention to the right block that talks about examples of observation from the material irregularity process. We were trying to highlight what we are seeing, what the change in culture we are starting to see in the sector after we've implemented the material irregularity process. Yes, it might not be as fast as we want it to be, but we are starting to see some shift within the sector, even though would want this to happen faster. So yes, so those are the stricter processes that we are applying around instances where there's no consequence management, or where there is instances where whatever transaction that happened meets the definition of an MI process. That is covered in there. I will then hand over to Dr. Mlapane to address the adult clinic process and how the departments are self-assessing. I think the other part the department can present, but based on our understanding, that she can reflect on that. And then I'm hoping that Tembiso, our infrastructure colleague, is on the call to then deal with the infrastructure part. Over to you, Dr. Mlapane.
Thank you, Tabelo, Honorable Chair and Honorable Members. I'm just going to address the issue around ideal clinic realization and maintenance issues that we raised on the issue of the self-assessment, in terms of the credibility and accuracy of that assessment. At the clinic level, we have seen that there is more structure, more than the hospital level. So even though the facility itself will do a self-assessment, we still have teams that will be coming from the district in the form of the district permanent perfect team, who will, over and above that clinic self-assessment, do the assessment. Though it's still a structure within the Department of Health, it's a bit of a structure outside the clinic or the facility itself. So the team from the district will do additional assessment for the clinic. So in terms of the outcome of that assessment, yes, they will indicate whether the elements that have been assessed in terms of the non-vitals, the non-negotiable vitals, the vitals, and the essential were in place or not. And given that outcome, answering the Honorable Chair around the grades of the compliance, they will then indicate if the facility is ideal or not. If a clinic is ideal, on non-negotiable vital elements, it needs to be 100%. But whether it's gold, platinum, or bronze will depend on your the achievement on the vitals. The higher you go, the better your status. But the first part is you have to have had 100% compliance on the non-negotiable. So in terms of whether the facility that is being addressed as ideal will actually perform or produce better outcome. The ideal facility it's supposed to be not only ideal in terms of attaining the status, but there's a requirement of maintaining that status. Because if you look at the indicator in the MTSF, it's not saying the facility is supposed to attain, but the facility is supposed to attain and maintain. That means if that facility today had an ideal status, if someone comes 2 weeks later and assess that facility should still be ideal because it has maintained its ideal status. And if that is a case, and the facilities are not just preparing for the assessment, but they're actually putting systems in place around if there is a gap, the quality improvement plans, are they monitoring that they're being implemented? And are these services being improved to cater for that quality of service? I'll give you an example. One of the non-negotiable vital elements is an emergency trolley that needs to be restocked after each use and on a regular basis. Because if a patient comes into that facility and the previous patient had used certain elements like your NG tube or whatever element that is supposed to assist in resuscitating that patient, if the maintenance part of that emergency trolley is not taken into consideration in the day-to-day functioning of that facility, the next patient is going to suffer. So the question should not only be around, has the facility attained, but has the facility maintained? Because that's where the quality of service will arise from. That means every patient that accesses that service has got the possibility of receiving a proper service because that emergency trolley is replenished with each use. So what as an office we did was around the APO work, we did a value add work on the facilities. So the clinics that the regularity auditing was done that were already assessed as ideal. We just look into had they maintained the ideal clinic status. So we still are having the issues around maintenance of the ideal clinic status. But in terms of the elements that are set into, like my leader, Tabelo, indicated that ideal clinic assessment and ideal hospital self-assessment are very comprehensive. And those elements are critical in ensuring that the facility is able to provide the quality of service. The only thing that we need to be making sure that the department is doing is having their facility ideal and maintaining the ideal status of those facilities. By maintaining the ideal status, they will go a long way in ensuring the quality of health service. The other question that was raised was around the issue of backup electricity generators. If the department had committed to having all of their clinics having that. In terms of the ideal clinic self-assessment checklist, backup generator is one of the vital elements that is supposed to be there. So in essence, it means for that element, at least there has to be at least 60% or more of the facility being compliant with that element. So yes, it is an element that has been put in the checklist for the ideal self-assessment, and according to the criteria for making a facility ideal, 60% of the primary healthcare should have all the vital elements in place. Thank you.
Thank you, Doc. So, please, in summary, respond to the questions on infrastructure.
Okay. Good afternoon, honorable members. So in terms of the infrastructure, all the contracts that are in use, they do have a penalty clause, and the contractor have been penalized in some instances where they've delayed the project. So how it works in terms of the penalties, if the delay is mainly due to the contractor's non-performance, then the penalties will be imposed. But however, there's still that option where the penalties can still be negotiated, where the contractor might not be penalized for various reasons that are provided. And in addition, if the reason is mainly beyond of the contractor's control, for example, where the contractor was not paid on time and the project has been delayed, the contractor won't be penalized. And also where there was the issue with the adverse weather condition, where the contractor couldn't work because of the delay or disruption by the community, the contractor wouldn't be penalized for such things. So basically, any act that resulted in the delay due to the department not doing what they were supposed to do, the contractor won't be penalized. But then where the delay is mainly due to the contractor non-performance, then the contractor will be penalized. In short, all these contracts that has been applied and that are currently being used by department, there is a provision for penalty clauses. And in some instances, we have seen where the contractors have been penalized. Thank you. Over to you, Tabet.
Thank you so much, Thembiso, for that. As they were talking, honorable members, my team was reconciling some of the questions that I missed. There was the question around, do we analyze the targets that were instances, I think the FFC indicates that there are some departments that are setting the targets low. We did not necessarily analyze that. What we usually do, because our focus is usually on the indicators that are on the MTSF and targets, so we then look at those targets that are already set at MTSF level that the department or the sector then cascades down to their APP. So we have not done an assessment on whether the targets the department is setting are actually lower than what they should. There's a question around if the committee is doing enough. I think from our side, I think the first interaction that we are having with the committee. And we will allow the committee to then go through the first year. I think I would most probably be in a better place to respond to that question after the committee has gone through 1 year. But I think for us it's critical that the recommendations that we include on the slide on what the committee should do, that they are implemented, especially on holding the sector or the departments accountable on a quarterly basis. They come and they present to the committee, the committee to remember some of those commitments that they've made, the committee to remember some of those action plans that they've made, and then inquire and follow up on those ones to say what is happening here and what is the progress. I think that will go a long way for the committee. But honorable member, allow me to say next year when I do come back to present, maybe I'll be in a better position to be able to reflect on what how the committee is performing. There was a question from the chair around listing. He wanted the details. So what happens is for an entity to comply with the PFMA, they need to be included on the list of the entities that are supposed to comply. We call it listing. They are called PFMA listed entity. So the Treasury releases a list of entities that are required to comply with the PFMA based on the definitions that are there. So with the CCOD, for a number of years, while it was still called CCOD, they were not individually listed as an entity that should comply with PFMA because they were treated as a trading entity. However, through the assessment and the consultation process between the department as well as Treasury, a conclusion was made that actually they need to be listed separately as an entity that should comply with the PFMA. That's the Mines and Works Compensation Fund. So because that final, and the process is that the minister then applies to National Treasury to include the entity as a PFMA listed entity, and then only when Treasury has approved and listed can they start processes. So that's what happened. So that actual announcement or approval only happened on the 28th of March of 2023, the previous year. Unfortunately, it was a short time for them to quickly prepare a stretch plan and annual performance plan for the year that was just starting 1 April 2024. So I think that's what we mean by the fact that because the listing was late, there was no time. And unfortunately, they also were not given an exemption from those processes. And therefore, when we audit, we have to unfortunately audit them against the PFMA requirements. So that's what it means. That's it from our side, Honorable Chair. If I did miss a question, I will ask the honorable member to assist, but I think we covered all the questions from our side. Thank you.
Yeah. No, thank you very much, Honorable Ma'am, for this part. I'm going to request that our secretary note these recommendations and maybe just put them, Ms. Machalamba, in this order, because AG sometimes they are very innovative. They put them in a cycle, they put them in a wheel. So we would want to have them tabled 1, 2, 3, 4, and engage very seriously. Not only to engage the minister on Friday, on the day we meet them, but also to keep it as in our dashboard all the time and be able to tick the progress. So I don't want this to disappear because they were very detailed. That's why I was saying to them, for them to cover us that well, they just needed to point the highlights. And I'm glad that we are not going to be sifting through where they are well written at the end of their presentation, and we'll take the minister and the department on those ones. So thank you very much. We will then come back, but I must apologize because the AG had requested to meet the chair separately much more before this meeting. Let me just blame Ms. Machalamba, who did not arrange a meeting between me and yourself. It will happen in the next future, and maybe it might even happen after all these reflections, so that I can also be driving this committee according to your desires and plans, and then we'll take it from there, because we do take your presentation very seriously, and we will have to make time to meet with you. I will have to go and plead with Ms. Machalamba to arrange my meeting with yourself. Thank you very much. You are then released. Honorable members, we would want to cut your lunch to 45 minutes. If we could have the next presentation logged in at quarter to 2, that would be great.
But Chairperson, can we keep to the program? It says 1 hour. Please let us have our 1 hour break.
Yeah,
lunch.
no. That's when sometimes the chair would override you because other people have requested something else that you don't know for the afternoon. So we will request that we are convened at quarter to 2. Thank you very much. 45 minutes.
Recording stopped.
Honorable members, we just have a half a minute to start. Thank you. Right. Honorable members, good afternoon. I hope we have had some rest and lunch. I must
Recording
offer you
in progress.
thank you for really agreeing to start at this 10 minutes earlier, 15. We quite a lot to cover, and I'm also thanking you for agreeing to limit our interactions so that we could really cover. This is the third presentation we have for the day. I am seeing an icon written Professor Glenda Gray. I am surprised they're still detaining her in MRC, but we'll hear the story, whether she's still in the MRC. Oh yeah, no, she probably is, yeah. She's working in there again, yes. Welcome, South African Medical Research Council team. We are here in the Portfolio Committee of Health, having had some few, in the few weeks back, having met with you, getting to know who you are, where are you up to, just to orientate ourselves, some of us as new members. But here today, we want to actually get a progress on a report based on the annual performance plan that you had. So you do have 45 minutes to make a presentation. Members will engage with yourselves, and then you can then, those clarity-seeking questions also being given to us. But this opportunity is given to you now to introduce and then start the presentation. Thank you very much.
Good afternoon, Chair and honorable members. It's an absolute pleasure on behalf of my colleagues at the SAMRC to present our annual report. My name is Ntobe Bondusi, and I am the President and CEO of the South African Medical Research Council. And in the room here, I'm joined by my colleagues from the Executive Management Committee of the SAMRC. So if we can please project our slides. And maybe while we project our slides, I'll just quickly invite my colleagues in the room to very briefly introduce themselves. And we'll start with Professor Liesl Zulke.
Yes, Chair, Honourable Chair and Honourable Members, it's Liesl Zulke. I'm the Vice President of the South African Medical Research Council, and my particular portfolio is the extramural unit as well as the internal research portfolio. Thank you very much.
Thanks, Liesl.
Sibuyile Ngongwa, the Chief Financial Officer for the Medical Research Council.
Good afternoon, Honorable Chair and members of the committee. My name is Mzim Topo. I'm the SAMRC Legal Counsel. Thank you.
Good afternoon, Honorable Chair and the members. My name is Ndosa Bam. I'm the Executive Director, Human Resources.
Good afternoon, Chair and honorable members. Mongi Zimguli, I'm the Chief Research Operations Officer. Thank you.
And Chair, I wish to acknowledge Professor Johnny Mahlangu, who is Chair of the board, together with several members of the SAMRC board who are in attendance online. So if we can just project our slides, please. So, Chair, I would like to start by reading this history and health statement that the SAMRC developed a few years ago, which acknowledges our complicity in the catastrophic and persisting consequences of colonialism and apartheid, including land dispossession and the intentional imposition of educational and health inequities. And in making this acknowledgement, we commit ourselves to the continued promotion of justice and dignity in health research in this country and beyond. Our presentation is going to be occurring over 5 parts. We will start by making some introductory comments, followed by our human resources, and then our performance, our financial information, and to give you some exemplars of stakeholder engagement over the last year. So our work as a Science Council is...
May I guide you and assist you? I was making in my preamble that you met us about 2 months ago. So,
Yes.
And 2, this presentation has already been forwarded to us. Take it that some of the things that we are going to raise, we know them and therefore go a bit faster on them. Thank you.
No, wonderful. Thank you very much, Honorable Chair. And so our mandate, which is based on the SAMRC Act, is linked with our vision of building a healthy nation through research, innovation, and transformation. And this is underpinned by our values of pioneering, excellence, respect, the partnerships we build, integrity, and citizenship. This is the board from the last reporting period. And I would just like to highlight from the forward by the board chair, who highlighted the commitment of the SAMRC to enhancing health and well-being of all South Africans. This commitment reflected in our operation lawfully, responsibly, ethically, and with integrity, and to good governance. And in this period, he bid farewell to Professor Brenda Clay and welcomed me as the new president and CEO. In terms of the executive management, it was led by my predecessor, Professor Gray, and the executive management remains the same. And since 1st of July, I have taken over the helm of the organization. And in her parting words, Professor Gray highlighted some of the advances in the last year, reflected through important partnerships, for instance, with the German government, with a donation from the German Development Bank, KfW, to promote vaccine development in South Africa, but also a new relationship with Thermo Fisher to allow the establishment of a Center of Excellence for Training in Molecular Biology through the SAMRC. And she expressed her gratitude to the staff in the National Department of Health that enabled her work. And in starting my tenure, I affirmed our commitment to delivering on quality research, high impact science, and ensuring health sciences that flourish, as well as focusing on funding research based on our local development priorities. And in celebrating our 30 years of democracy, reaffirming our commitment to promoting the health, equity, social justice, and evidence-based healthcare. And similarly, continue to build strong relationships with the minister, deputy minister, and colleagues within the Department of Health. So to summarize our current HR stance from the previous reporting period, you will see that the employment profile of the organization is 2/3 female and 1/3 male. And by race, predominantly African, 54%, and then colored making up 23%, 11% Indian, and 8% white, and foreign nationals make up 4% of the organization. And in terms of the senior management, this has remained fairly steady over the last reporting period between 2020 to 2023, 2024, with about 20% African, 20% colored, and about 15 to 17% Indian, and about 42% white. In terms of the senior management by gender, more than 50% women. And our executive management has seen, given the small number, a big change with my arrival, moving from 37% Black African to 50% Black African, 25% colored, and 25% white. And over the last 3 periods, our executive management gender distribution has remained unchanged, predominantly women. And now we move to the transformation targets. And what you will see is that during the period from 2014, 2015, highlighted in navy, compared to the period 2019 to 2020, highlighted in blue, and then 2022 to 2023, highlighted in green. You will see the number of unit directors has increased from 17 to 26. The percentage of female unit directors increased substantially following a special call for female unit directors. And the number of Black unit directors also increased substantially from 35 to 57. And this was also enhanced by a special call for Black unit directors. And the number of institutions that were recipients of these EMUs also increased from 5 to 14, showing the breadth of our national reach, as well as the number of provinces increasing from 2 to 7. And in the period between 2022 to 2023, we show some of the differences with increase in the number of female unit directors, as well as Black African unit directors. And shown differently, you can appreciate the number of institutional recipients of extramural units over this period from 2014 at 4, and now 14 in 2024. And this is shown differently, the number of EMUs by province increasing from 3 to 7 over this period. And if we look at the number of EMUs that are based at historically disadvantaged institutions, you will see an increase from 2 in 2014 to 6 currently. And now we focus on the distribution of scholarships and research grants. In terms of our granting programs, we have scholarships. These support scientists and clinician scientists in different categories. And so we have the Bongani Mayosi National Health Scholars Program that focuses on clinician scientists. We also have the Clinician Researcher Development Program that focuses on doctorates for medically qualified individuals. We also have an internship program that we run in multiple units within the MRC. And then we have a researcher development program, and more recently established programs for training in vaccinology. And in terms of the research grants, we have intramural postdoctoral grants, the clinician postdoctoral career development grants, the early and mid-career scientist programs, and a very comprehensive research capacity development initiative that focuses on historically disadvantaged institutions, and a nested PhD program. And I'll show you our investments in these. But summarized on this slide, you will see that both the total grant allocation and the number of recipients of grants have increased substantially over the reporting period. And so if we look in a bit more granular detail and we look at the scholarship recipients by population group, you will see that there's been a substantial growth in the number of Black African recipients of scholarships from the SAMRC, while the other groups have remained fairly steady. And again, this has been linked with the substantial increase in the number of research grants for Black African scientists over this period. If we look at the gender of the research awardees, you will see a substantial growth in the number of female recipients over this period. And when we look by institution, there's been a substantial increase from 5 institutions in 2014 to now 15 institutional recipients in 2024. And this is an area where we are paying particular attention to see how we continue to support the growth of institutional recipients across all universities in this country. Shown by province, this has increased from 5 in 2014 to now 15 in 2024. And when we look by both ethnic group and gender, you will see a substantial growth in the number of Black African and colored recipients, and most of our recipients are also female. And when we look at the overall distribution of scholarships by institutions, they still go predominantly to the research-intensive universities, but you will see institutions like UWC, NMU, and Northwest University begin to increase. But I think it's worthwhile to point out that even those individuals who receive these scholarships at the established universities tend to be predominantly Black African and female. And so our performance indices for this reporting period. So we will report on the financial statement, on the performance. And so in program 1, which is to administer health research effectively, our goal was twofold. One, to obtain clean audits from the Auditor-General, and not to spend more than 20% of our baseline budget on administration. And you will see that we achieved this well with clean audits over 9 successive years, as well as less than 20% of the budget going towards administration. In terms of program 2, leading the generation of new knowledge, you can see our targets reflected on the slide. And impressively, you will see that our performance far surpasses what we had aimed for in terms of the numbers of accepted and published outputs by SAMRC affiliated or grant holding personnel, as well as the number of first and last author publications and research grants awarded by the SAMRC. And when we look at program number 3, which is support through funding and other mechanisms, technology development. You will see that the targets for new innovation and technology projects, again, are significantly outperformed. The funding for innovation and innovation disclosures continue to be above our target. When we look at program 4, where we look at building human capacity for long-term sustainability of South African health research, the number of awards in terms of scholarships, the number of awards to female scholars and scientists and to Black South African scientists have been exceeded in terms of our targets. And when we look at our awards to postgraduate students and early career scientists from historically disadvantaged institutions, this is an area of growth. We had set very ambitious targets given our stronger intent in this area and didn't quite meet them, but still performed quite well. And when we look at the number of MSc and doctoral students graduated over the period, again, far exceeded our targets. Then finally, in program 5, where we look at how we translate new knowledge into policies and change practice to improve health, in all of these domains, we exceed our targets in an exemplary fashion. And so to summarize our approach to priorities for funding, we have research grants that fall into either strategic program or grant programs, as well as strategic funding. And you will see the programs where we work and the key partners who support our work in these domains. Similarly, we host the innovation platforms for the country for health research, and you will see our key partners, including DSI, TIA, and the Global Health Innovation Accelerator. And in the next slide, I showcase our other major research programs with the MRC in the UK, focusing on TB implementation, non-communicable diseases, mental health, and antimicrobial resistance. Together with the Bill and Melinda Gates Foundation, we've had 4 very successful grand challenges on maternal, child, and adolescent health, antimicrobial resistance, infodemics, and climate and health. And we have a very successful collaboration with the Technology Innovation Agency on seed funding for medical devices and therapeutics, as well as indigenous knowledge systems. And on the right, very important pioneering innovations during the period of COVID-19, many of which continue. These include our program of wastewater surveillance, the number of ongoing clinical studies related to COVID-19, as well as development of novel diagnostics, and our approach to community engagement, and of course, the mRNA vaccine development hub, which we host for the WHO. And some important strategic initiatives that are ongoing with major partners around the globe. The NIH on HIV, with GARD-P on antimicrobial resistance as part of the BRICS community, and of course hosting the EDCTP locally, as well as co-funding on infectious diseases related projects. And we have a number of other important partnerships that we've listed on the slide. These include important partnerships on infectious diseases on non-communicable diseases on a genomic medicine platform and a precision medicine platform. And importantly, we lead work on innovation in healthcare, and these are the platforms that we support. And how do we measure our impact? And in this slide, I summarize how we do this. So our work can really be described as meeting the challenges related to the quadruple burden of disease. This includes maternal, newborn, and child health, non-communicable diseases, infections like HIV, AIDS, and TB, as well as violence and interpersonal injury, including gender-based violence. And the approach we take here is to focus both on disease and disease mechanisms, to focus on population health, as well as to focus on health systems, settings, and policy. And our research programs include 10 units that focus on health promotion and disease prevention, 4 that focus on maternal, child, and women's health, 4 units that focus on HIV, TB, and other infectious diseases, 6 that focus on health system strengthening, and 4 units focusing on public health innovation, and 9 biomedical research units. And we have 10 intramural units, 28 extramural units, and a number of important cross-cutting and enabling research platforms. And I've spoken a little bit about our research capacity development programs that support the development of postgraduate students, early and mid-career scientists, as well as senior scientists, with a strong focus on historically disadvantaged institutions, and described our strategic research initiatives, as well as our grant and innovation project platforms. So some of our exemplars in terms of the impact we are trying to achieve include this new partnership with INSEM, the French Science Council, focusing on tuberculosis scholarship. And so we have a commitment of 2 million euros from the French over a 3-year period. And this is paired with a substantial investment of nearly 20 million rands from the SAMRC. Another exemplar, which I mentioned briefly, is the new relationship with Thermo Fisher, which will allow us to upgrade our laboratories within the SAMRC for training in molecular biology and life sciences for upskilling of graduates so that they are able to be absorbed into the market and contribute to our knowledge economy in this country. Another important exemplar is the Brilliant Consortium, which plans to bring the development of HIV vaccines to Africa. So this consortium includes 8 African countries, and it is led by Africans to do research on important questions for Africans, and is supported through a large grant from the US government and the SAMRC. And one last exemplar is this important investment by the German government through our Department of Science and Innovation, where the Development Bank of Germany, KfW, has invested in the building of infrastructure for mRNA technology transfer. And the SAMRC is the implementing partner who will be executing this important project for the country. And now we come to our financial information. You will see that our revenue for the current year is 1.3 billion, 6% variance from the previous year. And this, when compared to our operating expenses of 1.4 billion, shows our operating deficit of 84 million rands. And we have investment income that allows us to be able to plug that deficit, so that the deficit for the year is only about 21 million rands. And to summarize our financial performance, you will see that while our baseline grant increased by 2.5%, our contract income increased by nearly 16%, and our rental income increased by 7%. And importantly, our investment income increased by 48%. And these have allowed us to be able to reduce that deficit. And the value of new research contracts are awarded in the last year, nearly 700 million rands. And so what you note is that our revenue matches our expenditure. And importantly now, our contracts income exceeds the baseline funding that we receive from the South African government. And you can see the trends in our baseline grant over time. And finally, to make some comments about stakeholder engagement and our commitment to social responsibility. So we take this very seriously, and I am very fortunate to be supported in the work that we do by a very competent corporate communications team. And some of the work that we do includes our engagement with learners to try and introduce them to science at an early stage, so that their love of science begins before they even go to university. And we expose them to the science and exciting work that we do within the SAMRC. In addition, we have awareness days where we celebrate the important health days throughout the year. And this is some pictures from our diabetes awareness fun walk and public engagement initiative. And you can see some of our staff members and their children and family members participating. In addition, we take important days like Mandela Day as an important opportunity for us to contribute to the communities that we work with. And an initiative of our transformation team is the Jars of Hope, where staff members donate food that can be distributed to those with need. In terms of our digital platforms, you will see that the traffic in all of these is substantial, showing the important footprint of our organization. Our website in the last financial year with over 130 million hits, over 100,000 hits on Facebook, 250,000 hits on Twitter, and nearly 1 million hits on LinkedIn. So thank you very much, Honorable Chair and Honorable Members. We'll be very happy to answer any questions that you may have.
Thank you very much, Professor Ntusi, for your presentation and your team. We wish you well. Firstly, congratulations. We are meeting you for the first time as a new CEO President of the MRC. You are going into an institution that is making us very proud in the country. We wish you well as you lead this institution that is really showing not only just South African, but the world, how to do cutting-edge research, but remaining focused and supporting us in our country and in the continent.
Thank you very much.
We're now opening up this space for members to interact with this presentation. And you will then note the questions, Professor Ntusi and your team, and then we'll come back and respond. Thank you. Honorable members, may I see by show of hands that
Chair, I think you're in mute. You've muted yourself.
Oh, sorry. Oh, yes. Dr. Leroux, you are the first one. I don't see any other hand for now. You start. I'll be checking if there are other hands coming up. For now, Dr. Leroux, start.
Thank you very much, Chair. Thank you very much for the presentation. I just wanted to ask some questions around the budget, but also around some of the research output. Can you hear me okay?
Yeah, Dr. Leroux, because we are seeing Professor Ntusi for the first time, if you are able to show your video, that would be fine. But if
Sure.
we'll understand.
Thank you, Chair. I'm on my phone and I don't know how to put. I'm not sure how to put the video on my phone. It doesn't seem to give me the option to do that, unfortunately.
Okay, fine. You can skip that. Yeah, you can skip that.
Thank you very much, Chair. My apologies for that. Thank you very much for the presentation. And I mean, we are indeed proud of the South African Medical Research Council and the work it does. I had a few questions just around the research that is being done. I see that many of the papers and the outputs are quite significantly exceeding the targets that are set. But I mean, I know that one of the things we speak more and more about in academic medicine is that there's a focus on quantity rather than quality. And so it would be helpful to get a breakdown of those papers that are published, how many of them are published in high quality journals. And also perhaps if you do an internal analysis in terms of how many of your papers you would regard as high quality. I mean, of course, every paper that's published in a peer-reviewed journal is usually of a certain standard, but it would be, I think it is useful to know of those papers that you published, how many really go into the top journals versus the slightly less prestigious journals, and which papers are really kind of very strong papers like randomized controlled trials versus reports or versus less robust articles. So that would be useful to know. I don't know if you have that data, but I'd like to find that out. The second thing was just in terms of revenue and in terms of your financials, just to get a sense of, wanted to get a sense of your other income. You say, you talk about your contracts, and I assume these are contracts with other research facilities for work that you're doing, for research you're doing. I see that you have the grant from the government, but there's other income. Could you just go into that a little bit more about what the other income is that you have? And then I just wanted to get understanding. I see that your travel costs you have significant travel costs of 57 million rands. That is a lot spent on travel, and those have gone up significantly. Could you just explain to us why those costs have gone up so much, and what kind of travel that pays for? Thank you very much.
The next one will be Dr. Thembekwayo. I see Honorable Clark showed her face. Maybe she wants to come in. I will recognize her after Dr. Thembekwayo.
And thank you, Chairperson. My first question is based on, we seek clarity on the performance targets for the period under review, as they appear to have been significantly reduced compared to the previous reporting period, i.e. 2021/2022 and 2022/2023. And the entity has for some time been overachieving its performance target. So we need some clarity on greater health outcomes? How do you balance the two? Does the SAMRC have a memorandum of understanding with NHLS for laboratory-specific services, especially for clinical trials? If not, why not? Cancer continues to pose a formidable public challenge. How has the SAMRC involved the Precision Oncology Research Unit and Pan-African Cancer Research Unit? The following one, South Africa has noted an exponential growth of lifestyle diseases comprising of obesity, as we all know, diabetes, hypertension, and metabolic syndrome. How has the department involved its extramural research units to counter the public health threats? Thank you.
Okay, thanks. Let me just check if Honorable Clark has got a question. And then if so, any other member, let me just check on the platform. There's no other hand I see. Honorable Teko will come after Honorable Clark. Thank you.
Thank you, Chairperson. I've been covered, and I'm not going to repeat again. I just want to congratulate the new CEO in terms of being appointed, because as we all know, this is one of our entities that really always do very good work and have great outcomes, you know, in terms of the end of the year when they present to us. So we're very happy to have you on board and keep up the good work that this entity, the MRC, has always been able to achieve. Thank you.
Yes. Honorable Keko. I didn't see her hand. Okay. There's always the saying that the new broom sweeps clean. Now, Professor Ntusi, you don't have any clean, you can't do cleaner than what is there, because it's very, very clean. There's Honorable Clark. All you need to do is just keep cleaning and then keep on doing. Because we're not saying you are coming to something that is challenged, therefore we need this new broom. You are just fitting into your biggest ever achievement. It be just to keep and steering this responsibility into the right direction. My comments, what you were very thin as honorable members, is to commend once more the institution for remaining audit very strong on the audit comments, Auditor General's comments about yourself. We would like to know what progress are you making on the non-communicable diseases. Some of us are very aware that your research and your support of government in Africa on HIV, TB is commendable, and I think we are going to manage and continue to do that. We are actually going to have a new pandemic in the country of non-communicable disease. So your focus and guide on this one will always remain key. We'd like to really get you helping us on that one. Now, we also must commend you on fast-tracking the transformation program. That has been an issue some of us have raised in the past. I think we commend you. You actually showed a lot of slides that are showing that part. If I were to just check, how far are you in maybe strengthening your both domestic and international partnerships in the strategic processes? I hope that one remains your focus. And what mechanisms are in place to manage, monitor, and evaluate the relevance and success of these partnerships that you do have? What specific mechanisms are in place to ensure research compliance with high standards and ethics and integrity in terms of addressing any potential conflicts of interest that might arise? And there was something that was actually raised about, I'm not sure about whether I saw it very well, some bit of a challenge with SARS. If you can just rehash that again, I might have missed to really see what actually is that. That there are certain challenges that are coming up with SARS and the MRC. If there is something like that, I don't think maybe I had it right, or it's a past matter that was raised. Those are the comments that are coming in from members. Let me check once more if there's any member I've left out. No, 1, 2, 3, go. Okay, those are the members, Professor Ntus, that have come in. Please support us with your responses on these ones. Thanks.
Thank you very much, Honorable Chair. And I want to start by thanking you and the other honorable members of this committee for the very generous words of recognition of our work, its impact, the stronger governance organization, and the commitment to excellence at every level of the organization. So to start with the questions by Honorable Leroux, he asks about the quality metrics that we use to assess our work. Without having the exact statistics in front of me, I can assure him that the vast majority of the papers we publish are in what we refer to as Q1 journals. These are the highest impact journals. But we also recognize that we work in multiple disciplinary areas where impact is measured in different and nuanced ways beyond just impact factors. And so we look at the impact of our work on national and international policy, and it features prominently there. We look at the impact of our work on development of national guidelines that are used and developed by agencies like the WHO and the UN bodies. And again, our work features very prominently there. We look at the technical reports that are used to inform both the development of interventions and policies, and our work features very prominently there. And so we are assured that we are not just publishing for the sake of quantity, but producing science that is impactful, changing policy, and impacting positively on practice. And we've got many examples of those. To answer the question around our revenue, I mentioned that our revenue is about 1.4 billion rands. 46% of this coming from the national fiscus, and about 54% now coming from the contracts that we raise. And the nature of these contracts reflect our relationships with partners through co-funding of research, our ability to fundraise through relationships with industry partners, philanthropy, foundations, and high net worth individuals. And in relation to the increased travel costs, these reflect in a small way the travel that is done by employees of the SAMRC, but in a larger way, the increased contract revenue. And so under these contracts, we are mandated to do research that involves travel to research sites, and travel of our scientists to conferences. But also critically important to note is that we include the reimbursement of participants and the travel of participants to our research sites under this category, which contributes substantially to that budget of 54 million rands. In response to the questions by Honorable Tembekwayo, our targets have actually largely increased year on year. And the two areas where we've revised the numbers slightly downwards in two areas. The first is in relation to the number of postgraduate students and scientists we fund from historically disadvantaged institutions. I showed you the target of 80, and we achieved 68, which was still, I think, a very, very impressive achievement coming from the university, where we face similar challenges in working with historically disadvantaged institutions. I think this is a phenomenal performance. And so we've revised this number downwards for the coming year to 60. And then the other area is recognition of the inflation in outputs related to COVID-19. And so we have continued to outperform in terms of knowledge generation, but you will see that the numbers have been revised downwards and slightly higher targets than what we had during the pre-COVID era. And it's important to note that our MTF has informed much of the targets that we've developed over time. And then there was a question in relation to whether we have an MOU with the NHLS. I'm not sure if we have one, but I'm happy to report that we have an exceptionally strong and close working relationship with the NHLS. And I am informed that one of our research units, the HIV clinical trials unit, HIDRU, has a accreditation by the NIH for conduct of clinical trials, which is supported by the NHLS. And we, in relation to the question around precision oncology and cancer research units, I'm going to Professor Zulke to respond around the work of these extramural units within the SAMRC.
Thank you very much, Professor Tusi, and thank you again to the honourable member for that question. You mentioned in particular two units, or one unit and one larger initiative, the Precision Oncology Unit and PACER. Those are both based at the University of Pretoria and are in fact extramural units, the Precision Oncology Unit of the SAMRC. We are involved in a broad range of inputs around cancer. These spread quite clearly from bench to bedside to community. So within our basic science units and platforms, within our intramural units, within our extramural units, both the Precision Oncology Unit as well as our Pharmacogenomics Unit, as well as one of the other very specific genetic oncology units. And then, of course, in our intramural space, the community aspect as well, with our health systems unit and several of our other units being involved in key interventions around oncology. We also have a link with our clinical centers. We have one based in Khayelitsha and one based in the Eastern Cape, as well as a very close working relationship with the National Department of Health around our Eastern Cape Cancer Registry, and now the National Health Registry as well for cancer. So there a great deal of work and research going into cancer at the moment. In fact, I leave here to fly up to Pretoria to join with the National Department of Health in a consultation around cancer strategy. And we are also developing a more comprehensive cancer strategy to appropriately meet this issue, as the honourable member raised, of increasing cancer diagnoses within our country. Perhaps with your permission, President, I can also mention the obesity discussion. So there was a question also from the Honourable Member Tim Maguire around obesity, around the non-communicable diseases areas. And again, there's a very strong focus both in our intra and extramural program around all of these. We're trying to formulate a more comprehensive approach as changes have happened also within our own units, and we want to integrate this as a strong theme running even through our health strengthening units, for example, so that we can see that we are dealing with all of the approaching changes in data and in trends around these very specific issues. One of the more interesting projects at the moment is looking at the incidence of cancer and major adverse cardiovascular events, which is being run from our burden of disease research unit, because one of the biggest issues, as you know, with dealing with an issue is understanding the epidemiology of that issue in terms of the numbers. So we are very much involved in that process. And finally, just a comment about the underpinning value system there is about collaboration with multiple stakeholders, including the clinical services, the universities, and most importantly, the national department. Thank you.
Thank you very much, Professor Sote. And so if I can just add comments around cardiometabolic health projects within the SAMRC. We've got a very strong non-communicable diseases research unit that has long been leading work on epidemiology of cardiometabolic disease, looking at clinical trials to combat these, but latterly starting to embark on implementation science projects that can inform health systems strengthening around improvement of cardiometabolic health in this country. In addition, one of the new partnerships that we are looking into is with Novartis to look at how we improve our understanding of cardiovascular disease epidemiology in this country, how we understand access to care, and how we improve health systems strengthening for improved cardiometabolic health. So, Honorable Thembekwayo, I hope we've addressed your questions fully. I wish to acknowledge Honorable Clark and to thank you for your comments. And Honorable Chair, thanks for your questions. So, as an incoming and new president, I've recognized the apparent discrepancy between our funding and the burden of disease, and identified, as you articulate, NCDs as an important area of focus for our work and investment going forward. And in coming years, we hope to align our funding streams as the SAMRC better with the burden of disease. And so in doing this, we plan to work closely with government to understand the important questions and gaps that exist, to work closely with our partners at the universities and in civil society in addressing this epidemic of NCDs. So there is a question that was asked about our domestic and international partnerships. I did highlight these in my presentations, but perhaps I can summarize them very briefly. So we have strong partnerships with governments, and the relationship we have with other BRICS countries through the BRICS Research Network is one such example. But we also have got very strong partnerships with other co-funding agencies, like the National Institutes of Health and Fogarty in the US, the MRC in the UK and Wellcome Trust in the UK, the Bill and Melinda Gates Foundation, Inter alia, many others. In addition, I've shown you in strategic areas of focus, we've got specific partnerships that allow or enable our work in relation to infectious diseases, for instance, the ANRS partnership, the partnership with the government of India, in relation to NCDs, the role we play in the Global Alliance for Chronic Diseases, which enable South African scientists to compete for global funding in that space. We also do important work in relation to maternal, child, and neonatal health, as well as adolescent health. And one of our important partnerships in this area is with the Bill and Melinda Gates Foundation. And we have had a huge increase in the number of partnerships during the period of COVID-19. And we've been very fortunate to be able to sustain many of these partnerships as we are coming out of COVID-19. So I hope that gives you a flavor of the kinds of partnerships we have. In addition, we build an important partnership with industry. I've highlighted two examples in my talk, the partnership with Novartis and the partnership with Thermo Fisher, but there are a number of many industry partners that we work with. And you might ask yourself, how do we choose the partners that we have? We aim for partnerships that are predicated on shared value and ethics. And so through our work, we look for partners that enable us to be able to promote human rights, human dignity, and social justice for the work that we do. There is a question that is asked about how we ensure research compliance. So the domain of research ethics and integrity is a core aspect of our work at all times, ensuring that our research and science is professional, ethical, safe, responsible, and accountable. And we have a number of mechanisms through which we uphold research integrity to ensure credibility of our work. We have an ethics committee, as well as a highly regarded Office of Research Integrity that is housed within the SAMRC. In addition, we make it a requirement for all the research we fund to ensure that it is aligned with the broad ethical principles of beneficence, non-maleficence, and distributive justice and respect for persons at all times. And in the case of research involving animals, we ensure that these animals are well protected in terms of their welfare and interests, and at all times we reduce the amount of harm that can be done. And so this is an area that we take very seriously as part of our work. In addition, around the issue of compliance, one of the major corporate legs that we have within the SAMRC is ethical and legal compliance. And we have all of our contracts that we undertake are vetted through them to ensure that all aspects of our work meet ethical and legal compliance at all times. And in closing, Honorable Chair, I and all members of the executive committee are not aware of any issues with SARS. And perhaps I can invite Dr. Mdluli to comment briefly to amplify our response in relation to your final question.
Thank you, Honorable Chair and Honorable Members and the CEO. Chair, we did report about the SARS issue during the last financial year, and that was note 25 under the finance costs. So you would note that in this current financial year, for the reporting period 2023-24, we did not include that. So our finance department has been following up on that, and it's my understanding that that issue was resolved. If not, we will come back to you, Chair, and give you an update. But it was note 25 during the financial period 2022-23. Thank you.
Okay. So, Chair, thank you very much for this opportunity to meet some members of your committee and to respond to the questions. I'm going to hand over back to you and see if there are additional comments or questions.
Thank you very much, Professor Ntusi. We are not done yet. I've just received another message here from one of our members, Honorable Heko. She was not able to speak, and then her question is as follows. Of course, it's not coming in from your presentation. It's related to these international and national partnerships. We are now aware that in 2024 December, South Africa is going to take the presidency of G20, and there would therefore be, that is a bedrock of the whole of Africa. Now, further than that, G20 is going to move to much more resource countries. I mean, it comes from Indonesia, India, and now Brazil. South Africa will be a fourth in the row. What would you advise government are the research focus and areas where we must enhance, because after G20 leaving South Africa, you are not going to be, as a country, as a continent, very strong in influencing that, because then that must actually come in the advice and the influence of what could be in the forefront of this would be what you might probably be sharing and advising the government. We will be interested to know in that space whether there's been any discussions as yet that have been started by yourself, being a reputable institution in our country on research, with the government going to focus this ever once-off type of an event in the world. Maybe I'm paraphrasing what Honorable Teko raised in terms of this thing. Thank you very much.
Thank you very much, Chair. This is a very important question, and some of us have recently returned from the UN high-level week in New York, where we participated in the Science Summit, but also had an opportunity to engage with colleagues from the National Department of Health and from DSI around the health and science planning for the G20, where we have been asked to give input. And we will be doing so. In terms of your question around areas of priority specifically for health, I think that there is a need to still continue focusing on the quadruple burden of disease because this has relevance not just for South Africa, but for the global South. And so to look at how we better deal with the challenges of infections, in particular infections like HIV, tuberculosis, malaria that are endemic, to look at endemic non-communicable diseases, including cancer and mental health, to look at challenges of maternal, neonatal and child health. We are seeing some regression in attaining our targets, both in some provinces in this country, but in a number of countries in our region. and of course, to systematically deal with the challenge of violence and injuries. In addition to this, I think that there is an important need to focus on universal health coverage and strengthening of health systems. And I think this will be a major focus for the next G20 from the preliminary discussions we've had. The other three important areas that I think the G20 meeting needs to focus on, in my view, relate around the relationship between our changing climate and the impact of this on health, the use of digital platforms to inform how we understand all aspects of health, from diagnosis to prognostication, and using digital platforms, large language models, and artificial intelligence to improve efficiency of our work. And then finally, the challenge of antimicrobial resistance, as well as our readiness to deal with emerging pandemics. These are for us key priorities, and as we give input to the country's planning for the G20, these will feature prominently in how our thinking comes across. Thank you very much, Chair.
Yeah. No, thanks. Our future is in safe hands in the MRC, and we welcome that, and we hope that you will be able to actually influence our policymakers in the country, in Africa, to take some of these recommendations and these points that you have just raised very seriously, so that that meeting and that event could have an impact lasting in our continent. Honorable members, there are no further clarity-seeking comments. Maybe next time we will release them much later if we engage. We thank you very much, Professor Ntusi, and once more welcome to the leadership of this institution that really has been a remarkable institution and continues to be doing so. So you have a space and time to make your mark during the leadership, and we hope that you'll do just as good or even much more than some of the colleagues. For us, we have no real negative comments about yourself and the institution, but only praises. And we hope that you will then continue in that trajectory for the sake of our country, for the sake of the continent. The continent of Africa looks up to South Africa for guidance and support. Among other things, they look to us is issues of research and issues of this science that is generated within your space. And we wish you well. We hope to meet you again. I'm going to be influencing my committee members to visit your site very soon. We are new members. We need to visit. It's just around Cape Town. Just take half a day to be there and come and be educated and learn as much as we can. So members, I don't think it will be this year, because our program is very tight for up to December. But please open your doors for us somewhere in next year to come and really see your institution and yourself in person. Thank you very much. Have a good afternoon.
Thank you very much, Chair, and to your committee for the fantastic engagement. I wish to acknowledge and thank our members of the board who attended this briefing, and it will be a delight to host you and your committee at the SAMRC, and I will reach out to your office to set that up for next year. Take good care.
Thank you very much. Honorable members, we are trying to then start at quarter past 3. We just need another 10 minutes to make sure we get the new presenters to come in. The next one at quarter past 3. So take another tea break. Honorable Dr. Tembe Gwayo, this is tea time. Up to be back be back at 3:15. We'll try and
Thank
chase
you, Chair.
We'll chase this new presenter to come in. Ms. Majalamba, can you get us the team from Dr. Berikis Nasambi, CCODD, please? Thank you. Tea time.
Hi, Chair.
Okay. I noticed that Dr. Kisna Sami, Dr. Ntantam Jali, Dr. Paul Rabada, and Dr. Botes are all logged in, and maybe some other people I may not know who are part of this team. We will be starting in less than a minute with a presentation from Commissioner of Compensation of Occupational Disease and Medical Bureau. We will then want to give this space to you, Dr. Isnasami and your team. Thank you very much, members, for holding on to now. This is our last presentation for the day. You have really been so supportive of this process. That is our legislative obligation that to do. Just hang on there. You will be able to be released within 2.5 hours. Go and watch Bafana Bafana, and then have other duties that we are going to be doing. Over to you now, Dr. Kisnasamy.
Thanks, Chairperson, and good afternoon to the honorable members and to colleagues who have joined. I'll just go on to slideshow and screen. Chair, is it showing properly?
Yeah, just put it on a slideshow. At least we can see it now. Now it's on the slideshow. Thank you very much.
Okay, thanks, Chairperson, and appreciate that we are once more presenting to the Portfolio Committee since the induction process. Just a note that I know you had a moment of silence when you started the program. I think it might have just been for goodwill for the committee. But I'm just asking, Chair, with your indulgence, for a moment of silence for the mine workers who, as a result of occupational injuries and diseases, never made it back. So if I could indulge the committee for a moment, Chair. Is that possible, Chairperson? To remember the mine workers who built this economy.
Yes, Dr. Kisnasamy, thanks.
Thank you, Chair. If colleagues could just say a silent prayer, or just to remember the people who built this economy, and our report is about them. Thank you, Chair. Okay, Chair, I'll resume my presentation, and thanks for the opportunity to come present our annual report. Just a minor change from past members who have noted when we've come to Parliament before. We used to present on the CCOD, and even the parliamentary paper refers to the CCOD. Since our listing as a Section 3A entity, it's now called the Mines and Works Compensation Fund annual report. So that's what I'll be presenting on, the Mines and Works Compensation Fund annual report, which is audited. There's some slight changes here and there, and part of the issue is the fact that we regressed a bit in terms of the audit because of the requirements of the PFMA. So I did present this to the committee previously in terms of the induction process, so I'm just going to skip that, other than that we've modernized a system that had collapsed in 1973. Essentially, the system comes from 1912, but modernized over the last 10 years, and in terms of the work that we do, in terms of compensation, one of the social protection schemes that affects workers in mines and works and ex-workers. So it's tracking and tracing, medical assessments, certifications. We pay compensation benefits for 6 occupational lung diseases. We collect money for the Mines and Works Compensation Fund, which we'll be presenting later on. And of course, one of the key areas we are hoping to bring to your committee in the 7th administration is the repeal of the Occupational Diseases in Mines and Works Act. This is the modernization process. Again, I spent time in the induction, so I'm going to skip it, other than saying that in terms of performance targets, which Auditor-General has queried, 6 of the 8 performance targets were met. So it's quite a comprehensive program that we've put together in terms of modernization of a very ancient social protection system, and essentially try to deliver better service to workers in mines and works and ex-workers. Just in terms of the legal framework, we were listed as a public entity, Section 3A of the Public Finance Management Act on the 28th March 2023. And there is currently a fraudulent claims court case. The wheels of justice, they are slow, but they do start. And this was a case that we reported to the Hillbrow court, Hillbrow SAPS, in 2019, and that case is currently being prosecuted in the Palm Ridge Commercial Crimes Court, and we could discuss that in the event of members wanting to know a bit more about it. But the unfortunate part with the Mines and Works being listed as a public entity, 3 of our findings from the Auditor-General relating to the performance report, the strategic plan, and the annual performance plan couldn't be done within 3 days, 28 being gazetted and by the 1st of April to be in Parliament, and it virtually was an impossible task. We had a strategic plan, an APP, annual performance plan for the CCOD, but Auditor General wanted a strategic plan and performance plan for the fund as listed, and I think Auditor General has confirmed that with the Portfolio Committee earlier today. The highlights is that we have continued support of the Minerals Council South Africa. I reported previously that we have a voluntary levy that supports the reforms at the MBOD, CCOD. We've had a proper actuarial valuation report, which gives us proper financials. The compensation benefits have increased by 20%. It's increased in the previous year, but effective on the 1st of April. So a first degree impairment payment will increase to 91,000 and a second degree to 200,000. So we've really upped our inputs in terms of raising the funding from the compensation fund. Of course, these are not retrospective, so it's only new claims that came in from the 1st of April will benefit from these increases. The levies that we collect funds from the mining companies was just dusted downwards, and this continues a trend of improved actuarial valuations, improved status of the fund, and therefore decreased levies to the mining companies, which hasn't yet at the same time we could increase the benefits. And of course, we worked very closely, as I'll point out later, with social protection funds and banks, etc. And very important, these were previous audit findings about non-functional governance committees, but our audit and risk committee, and some members are present today, our risk committee, and our advisory committee, which is made up of trade unions and Minerals Council members, mining company members, have been fully functional. Just to state, we have an unqualified opinion. The regression is that, unfortunately, we have material findings, which is in the annual report. Previously, we had an unqualified opinion with no findings. The material findings relating to the first 3 parts of it. Let me just go to my pointer options. So the annual performance report, the strategic plan, and annual performance plan are part of the Public Finance Management Act requirements. It was impossible. Well, it probably was possible within 3 days to do something, but not possible at all in terms of the frameworks to get it to the minister and then to the Portfolio Committee by the 1st of April, well, 31st March. Consequence management was an issue that goes back on material and findings on irregular and fruitless expenditure. Some members of your committee, Chair, will know that we had a collapse system, disclaimers, prior to 2012, qualifications on revenue, and then ultimately an unqualified audit. But in terms of our disclosures, Auditor General has been quite tough on us in terms of the fact that did we take interventions against staff, etc., and investigations. Now, the MBOD, Medical Bureau for Occupational Diseases, and the Compensation Commissioner for Occupational Diseases are directorates within the Department of Health. So in terms of consequence management, only the fund, the 5.8 billion rand fund, is a Section 3A entity. So the staff and any investigations have to be undertaken by other directorates within the Department of Health. So we referred the consequence management actions to the loss control officer and HR and labor relations within the Department of Health. And of course, that's something that would be picked up within the Department of Health annual reporting. Revenue management is within our framework. Again, in this financial year that we are reporting on 23-24, we collected 98% of revenue, but we are being held accountable for past revenue breaches previously where mines have closed or mines have not paid. We're currently pursuing one court case with a listed entity in terms of collecting revenue, but Auditor-General did make a finding on that because, of course, they stick to the 100%. And then the inadequate review of financial statements in the final print, final draft print to the Auditor-General, there was a printing error with a 0. But unfortunately, Auditor-General takes it as it is an error that needs to be reported on. And essentially, the report that you have now has got corrected financials, but Auditor-General decided to say that there was an inadequate review. This was related to a printing error. The business processes, well, this is what we do: certifications, claims finalized. And in brackets, you've got the figures for the prior year, the payment of benefits, 213 million, collection of levies, mines and works inspected so that there's no, that we can see that we're getting correct, accurate levies and income from the mines. The digitization project I mentioned, I showed you the collapse system with the physical files, and currently about 200,000 out of the 600,000 files are now digitized. And thanks to Rand Mutual, we really provided the funding and heavy lifting for the digitizing files. And this project was undertaken by Dr. Rabada and Kat van Heerden. Multiple linked databases. I've pointed out to you how we are trying to track unpaid benefits. And I gave you the figures last time in terms of this, and working very closely with banks, social protection agencies, the patient registration system, the pensions agency, SASSA, etc. Social partners, and Chair, I took the liberty of inviting our social partners. We are quite involved with BRICS Plus in terms of the TB in the mining sector and TB in general, the Stop TB Partnership in Geneva, the World Health Organization, the International Atomic Energy Association, the International Labour Organization, Global Fund and SENAC, universities, the Medical Research Council, and the TB think tank. And this has led to many of the innovations in terms of cutting-edge science being brought to bear. Some of the things I pointed out about computer-aided detection tools, the use of ultra-portable X-ray units, and we've had very strong support in also introducing this in terms of the BRICS program, which makes up 40% of the TB burden of the world. We have a functional call center, and we've got a functional website which we've said to members of the portfolio committee, and we probably still need to take that up as to who will sign up to help us with tracking and tracing from the constituency officers. These are the certifications, a bit of a dip in the 22 period because of the changeover to the electronic systems, as well as we had problems with the electricity supply and internet connectivity, but that's picked up. This is the levies, the claims paid. You can see that generally the numbers of claims are going down, and that's good because in a sense, the preventive interventions in the mining industry have really assisted in terms of the prevention interventions, and bulk of this is related to TB claims. TB has gone down considerably in the mining sector, and also some of the chronic occupational lung diseases like silicose, etc. But you can see the value has gone up. So we are glad that through the intervention of the political leadership and technically supported with the trade unions, the mining companies, ex-mine worker associations, we've actually had decreases and the prevention interventions are working. This is levy revenue. We had a major correction of the levy in the 2018-2019 period, and essentially it depends on risk shifts, but it's remained fairly stable. Overall, in this period 2018 to 2024, we picked up 705 million rand in terms of revenue, and I just mentioned the three major commodities of gold, platinum, and coal. This unpaid claims I've shown you all before. It's just an updated slide of 70,000 claims, still unpaid 1.35 billion. This 21-22 blip is the working closely with the Shia Miso Trust, and I want to acknowledge the close working relationship with this class action settlement fund. Those are the claims that have come through the Shia Miso Trust that we are also clearing. And you can see, Chair, that 23-24 period, we hardly have any backlog in terms of claims, unpaid claims. This was the big issue about the 53,000 claims before 2006, which still is a major issue for us in terms of the unpaid claims. And therefore, we have to work hard in terms of further work, in terms of outreach activities, etc. Challenges, of course, infrastructure and the non-sustainable one-stop service centers. I did show in the induction the one-stop service facility in Amtata, in Kuruman, in Limpopo province, and Carltonville. Unfortunately, sustainability has been an issue together with the provincial administrations, and the Global Fund had funded one-stop service centers in neighboring countries. We are picking up with the Global Fund to see if that can be brought back in terms of the TB in the mining sector project. And mainly we've been dealing with mobile clinics, and I gave you some examples where, Chair, yourself, you've been quite involved in your previous role as Deputy Minister in terms of some of the activities with outreach services. The service requests are currently still increasing from provinces and neighboring countries. We had a delegation from Botswana yesterday who asked, when are we coming to Botswana? And next week we'll have an outreach in the Free State province, fortunately funded by the Minerals Council, supported by the Office of the Premier and the MEC for Health in the Free State. And in about 2 weeks' time, we'll be going to Mpumalanga. So we're continuing to provide this, although it's an unfunded mandate in terms of service delivery. I did mention the flawed fund. The fund of 5.8 billion only covers the income protection side, unlike other social protection funds in the Department of Employment and Labor or Rand Mutual, where the levy should cover everything. Unfortunately, government has to cover these costs, and the Minerals Council has provided funding. Human resources, the bulk of our posts are still clerical, so there needs to be the upskilling. Fortunately, we've managed to bring in high-level technical skills through funding from the Minerals Council. And this is a major issue, Chair. We were listed as a public entity in terms of the Section 3A of the Public Finance Management Act. There's been very strong requirements in terms of it, but in discussions with National Treasury, they are not providing any funds. So it's something that we will have to discuss. I have raised it with the Director General and the CFO of the department that we have a PFMA structure, but with no funding in terms of the requirements for PFMA, and hence some of the findings that you found from the Auditor-General. This bill is in its final stages. We did mention it so that it can become the MBOD, CCOD, and the fund will become a fully fledged Section 3A entity. The mining companies have agreed that the levy will cover the full costs of the fund, including healthcare benefits, the administration, as well as the benefit medical examinations, etc. So hopefully in the 25-26 financial year, as we go through the cabinet and parliamentary processes, cabinet processes with the listing of a new bill, that we'll bring it to your portfolio committee to take forward. Funding for service delivery is still a problem, subject to support from the Minerals Council. There's been nominal increase in voted funds, which we'll talk through, and we're totally dependent on the voluntary levy. It's almost a 50%, about 60 million from the Department of Health through voted funds, and about 60 million from the Minerals Council, which is rising also. I'm going to hand over through you, Chair, to Mishak Maswangani, our Director of Finance, to take you through the financial reports. Through you, Chair, Mishak Maswangani. Is Mr. Maswangani?
Yes. Oh, thank you, Dr. Berry. Good afternoon, Chair, members of the committee, and colleagues. So I'll be presenting the voted funds financial report. So as members are aware that we are allocated voted funds by National Treasury through the National Department of Health for our day-to-day running which includes compensation of employees, goods and services, transfers, that's for the payment of the monthly pensions, and as well as capital spending. So our compensation fund levies are only restricted to payment of claims, actuarial valuations, and bank charges. So the current slide is showing the voted funds expenditure trends for for over 3 years up to 2023-2024 financial year, as well as the current year budget. So our total expenditure for the 2022 financial year was 59.2 million. Then for 2023 financial year was 53.2 million. Then for the current year, I mean the 2024 financial year that we're busy reporting, it was 54.4 million. So the budget allocated to us for the current financial year, which is 2024-2025 financial year, under compensation of employees, we have been allocated 37.5 million rands. Under goods and services, we have been allocated 16.9 million rands. I must also indicate that for the current financial year, our goods and services budget has been reduced by around 8 million from the previous financial year. So under transfers, we've been allocated 1.8 million, which is mainly for the payment of the monthly pensions from the previous ODIMA Act. So under capital spending, we've been allocated 6.4 million rands. And then overall, for the current financial year, 2024-2025, we have been allocated a total budget of 62.8 million rands. Next slide, please. Okay, next slide, please. Okay, so the current slide, it's showing the voted funds actual versus the budget for 2023-2024 financial year. So under compensation of employees for the 2023-2024 financial year, we allocated 35.3 million, out of which we managed to spend 34.8 million, resulting to 99% spending, which was 1% under expenditure. So that 1% was attributable to the vacant post that we couldn't fill during the 2024 financial year. So under goods and services, our budget was 24.7 million. That's what I've just indicated, that for the current financial year 2025, we have been allocated 16.9 million, coming from the 24.7 million. That results to the 8 million reduction in our goods and services budget. So the actual expenditure for 2024 financial year under goods and services was 18.7 million, resulting to 76% spending, which is 24% under expenditure. So this under expenditure was attributable to the pending service level agreements with the medical service providers for the benefit medical examination. So we have acquired the service of the medical service providers, but we couldn't start receiving the service because the service level agreements were still pending. So that resulted to the under expenditure under our goods and services for 2024-2024 financial year. So under transfers, that's a state contribution that we received from Treasury for payment of monthly pensions. So that was 100%. So under capital expenditure, we were allocated 3.1 million rands, out of which we only managed to spend 56,000, resulting to an under expenditure of 98%. So that big under expenditure was as a result of the cost containment measure instruction that was issued by National Treasury to ask all the departments to postpone all the capital spending during the 2024 financial year. So overall, our total budget was 64.8 million, out of which we managed to spend 54.4 million, resulting to a total spending of 85%, which gives us 15% under expenditure. So the under expenditure is attributable to the reasons which I've just mentioned. I will end there. Thank you so much.
Thanks, Mr. Masongani. Chair, we're going to go on to the fund. That was the voted funds that we get from Parliament through the Department of Health. We will now go on to the fund itself, the Mines and Works Compensation Fund, which is the income protection fund that pays the benefits to the workers in mines and works. I'm going to ask through you, Chair, that Ms. Mama, the Deputy Commissioner, takes us through this slide. Ms. Mama, through the Chair.
Thank you, Dr. Berry. Good afternoon, Chair, honorable members of the Portfolio Committee, guests and colleagues. I'm presenting the financials of the Mines and Works Compensation Fund as at 31st March 2024. I'll start with the financial performance of the fund, and I will focus on the current year, 2023-2024. Starting with the income of 127 million, which slightly increased from the previous year due to more risk shift work in the year. And going to the interest received, which increased to 466 million compared to the previous year, which was 323 million. And this is due to increase in interest rates and higher investment balances. And other income of 127 million, which represents movement in provisions and is from actuaries, leading us to a surplus of 416 million. Thank you. Next slide, please. Going to the financial position of Mines and Works Compensation Fund as at 31st March 2024. So in line with the increase in interest rates, our investments increased for 5.3 billion in 2022-2023 to 5.7 billion in 2023-2024. Receivables decreased from 28 million to 15 million, and this is because this year 98% of revenue was collected, and we do have some old debts, and the majority has been provided for. Going to cash and cash equivalents of 69 million, which varies as per operational requirements of the fund, leading the fund to a surplus of 2.8 billion compared to 2.4 billion from the previous year. And this is due to increase in interest rates and a reduction in liabilities from the actual report. And going to trade and other payables, which increased from 93 million to 103 million. And this is due to interest accrued on rejected payments. And now there is an extra effort put in tracking the rejected payments. The movement in both short-term and long-term liabilities is in line with the actual valuation report. Thank you, Dr. Berry. And jumping to the budget, the financial position of the Mines and Works Compensation Fund for the MTF period. So for the levy revenue, we are budgeting for a reduction in the first year of 127 million, which is in line with the reduced levy rates from the 1st of April this year. And from there, we increase the levy in line with the inflation over the MTF. Interest received, we are forecasting an increase, which is for the current year, to 502 million in the outer year, and this is because of higher investment balances. And pensions payables are from the previous act, as Mr. Masongani mentioned, and are decreasing to natural attrition. For budgeting purposes, so we aligned the movement in provisions with new risk shifts, and we are forecasting the profit for the MTF period. Thank you, Dr. Berry. Going to the financial position of the Mines and Works Compensation Fund for the MTF period, starting with investments and balances are increasing from 5.7 billion in the current year to 7.2 billion in the outer year. And this is due to interest receivables. And members, please, I'll jump to the bottom of the page to provisions. And we are forecasting the provisions will increase from 2.8 billion to 3.4 billion in the outer year. And we are happy to report that The surplus of the fund are forecasted to increase from 2.8 billion in the current year to 3.6 billion in the outer year. Thank you, Dr. Berry. Thank you, Chair.
Thanks, Ms. Mama, through the Chair. So just to report, Chair, overall, the fund is in a healthy balance, notwithstanding the increasing in benefits, payments, the benefit amounts, as well as the decrease in levies. I'm just going to go on to the performance report in terms of the fund itself. So efficient management is the database, and we did demonstrate the database to the members of the portfolio committee at the induction, and it's now state-of-the-art modernized database, 600,000 files, and with updates and links to the multiple databases, including like ShopRite, Checkers, Capitec Bank, etc. So that target has been reached, and we either do quarterly updates or 6 monthly updates, depending on the nature of the groupings we work with. And Dr. Botas, together with Andre Fourie, managed this very well to non-disclosure agreements. And I also pointed out the POPI regulator gave us permission to gain access to databases in terms of the process. So we really appreciate the fact that you can't hide under the regulator as well. In terms of the performance targets, with the certifications, 14,276 finalized, the target was 14,100. So that was achieved. Benefit payments were a problem where we only did about 60%. Claims finalized, again, about 60%, because they link to the benefit payments, benefits, as well as and the claims finalized. And then the 90-day period was very important. Month 1 for the lodgement of a claim, month 2 for the certification of a claim, and month 3 for payment if a compensable disease. And we managed to achieve 87%. And hence, my earlier slide on the backlogs of unpaid claims shows that this is working in terms of the work done by the leadership of Dr. Rabada and Dr. Machali and Ms. Mama and the team in terms of payments, and Mr. Masongani. Control mines liable for payments, 82% paying levies, and 80% of control mines was the target. But these 82%, that 98%, these are some of the larger mines, and ultimately the fact that 82% paid the levies, it made up 98% of our income. And then some members of your committee will remember that we never used to submit annual reports of the CCOD. We used to always seek apologies through the minister to the Speaker of the National Assembly. So this is there just to keep us in check that we are submitting on time. So this is the previous financial year, and we're currently dealing with the current financial year. So 6 of the 8 objectives were met, Chairperson, in terms of the activities. And then these are the controlled mines and works inspected through Ms. Baolo. The revenue team has been working very hard in terms of their activities, physically inspecting Katu, the Farflang copper mine, Springbok, Northwest Province, etc. And it'd be useful to know from your oversight visit whether you all had visited any of the mining facilities in Northwest, but that's for another day, Chairperson. Human resources, this is the framework for the CCOD, plus minus 33 full-time employees. This excludes the support from the Minerals Council, which brings in the higher level technical skills. And just to point out that the bulk of our personnel are below the level 7, so mainly administrative clerks in terms of this. And this is part of the upskilling as we move to much more of an online information data management system in terms of it. And the posts were frozen, by the way, which led to some of the issues that Mr. Masongani spoke about. This is the diversity mix in terms of race and disability. In terms of the Medical Bureau for Occupational Diseases, 36 posts filled. Again, the bulk of the posts are below level 7 in terms of clerical, and the senior technical posts, fortunately, we've managed to provide support from Minerals Council South Africa, and some of the clinical posts are now coming in. The certification committee and the medical service providers are funded out of the goods and services transfer. This is the diversity of the team at MBOD in terms of race and gender. And then in my conclusion, just to acknowledge your committee as well, Chair, been very supportive of us. I know you have to provide oversight, but we've appreciated both at the induction, and we'll hear today from your committee as to what's the next steps in as we go forward. Really important, the Minerals Council South Africa, for the heavy lifting it's done in terms of technical support. The Audit and Risk Committee members here played a very important role in helping us to achieve some of the unqualified audits, and led by Mr. Charles de Kock. We work very closely with provincial neighboring country governments and other national departments like Department of Employment, Labour, Department of Mineral and Petroleum Resources, Department of Social Development, etc. There are quite a few clusters that have come to the party in terms of assisting us. We work very closely with the trade unions, and in terms of also international partners and international trade union federations, ex-mine worker associations, some of them are present here, non-governmental organizations and social partners. And Chair, you'll find that in the screen there are colleagues from around the world that have joined us in celebrating the interventions in prevention and the fact that we created a better life, albeit we couldn't bring back health, but at least some issues on redistributive and social justice. Rand Mutual Assurance and the Sheemiso Trust also have been very instrumental in our growth. So, Chair, if we had stuck to our rules, this is the first annual report of the Miners Thesis Board, 1913. The Act was set up in 1912. So we hope that this is the 111th report to Parliament based on the initial setting up of the Miners Thesis Board in 1912. And this annual report is dedicated to the lives and livelihoods of the workers and ex-workers in mines and works who built the mining economy of South Africa. Thank you, Chair. Over.
Yes, Dr. Kisna-san, I know how passionate you are about this program. It actually showed in the last time you came to make a presentation to us. We could feel it and see it on that day. Thank you very much. While all the members are raising their hands, yes, we were in the Northwest last week, but we were not able to overlap with the other committee that was doing focus on that. So one of our members who's parked in both health and mineral and energy subcommittee, mineral resources and energy, will then be able to maybe find time to share with us what did they see there. But of course, they would have seen it in the eyes of their committee. And we still need to also make sure we are very close to the mining companies regarding this work. Honorable members, may I recognize those who would like to engage? It's not going to be Dr. Kisna-san again, unless you forgot something.
Chair, I just forgot to acknowledge the colleagues from the BRICS countries who are present here: Russian Federation, Brazil, India, China, etc. The colleagues from ILO, WHO, and colleagues from Mozambique, Lesotho are here. They are in the screen. You won't know the names, but I thought I'd just acknowledge because there are different time zones, but they felt it was very important to support us at this very important presentation. So I do apologize for interrupting, Chair, but just to note that we have a very strong presence and people have acknowledged the role of the compensation fund in improving the lives and livelihoods of workers in the mines. Thanks, Chair. Over.
Okay, thank you for that acknowledgement of there are some hands. I mean, there are certain, you're right, certain surnames that are sounding that are looking very much not like Kisna-Sami or Jomo or Van Staden. So they probably are all over the world. Thank you very much. I see there's one hand that has come up right now, that one of Honorable Paeko. Honorable members, let me just recognize her as you all are making up your minds to ask. Honorable Paeko will be followed by Honorable Senne in that order. And then the third hand is that one of Honorable Van Staden. Honorable Clark will be number 4 this time around. Honorable Dr. Leroux will be number 5. In that order, starting with Honorable Paeko, Senne, Van Staden, Clark, Dr. Leroux, and now Dr. Tembekwayo. Thank you.
Thank you, Honorable Chair. I welcome the presentation as presented by the team. And you can see and feel that this team is dedicated to this work. Chairperson, I also welcome the audit outcomes, though they report to have regressed, but it's still within the standards, the audit standards. Chairperson, this is a very critical fund as it addressed the challenges and health risks that were faced and are still faced by our brothers and sisters in the mines there. Most of these that we're talking about, most of them are no more. It's only the families that have still to find closure. Chair, my question would be, what measures do they have within the fund to curb fraudulent activities that may be there? I'm not saying they are there, that may be there within the fund. Are their systems responsive to that? Also, what risks are there? Do they have a risk strategy in place so that if there is any risk that they foresee, they are able to counteract that as a fund? Also, Chair, I am interested in understanding what can be done by the fund such that if by year 2000 and maybe 2010, Xhego was supposed to get a 10 rand. What can make Xhego to get a 20 rand now that it's 2024? And I was due for 10 rand by 2010. Now it is 2024. I'm just trying to make it very simple for other people to understand, not them, because they know. I also wanted to raise those few issues, Chair. Otherwise, we thank them for the presentation and the dedication that they seem to have for this program. Thank you very much, Chair.
Honorable Senne, thank you.
Thank you very much, Honorable Chair, and good afternoon to honorable members, the Commissioner and your team, and everyone who's in the platform. Chairperson, let me congratulate the Commissioner and his team for successfully, because when I see the audit outcomes, they have reached most of their targets under this year under review. That is a really commendable accomplishment, Chair, that reflects the team's dedication and commitment to safeguarding the health and the welfare of ex-mine workers in the mining and related sectors. Chair, I want to be a bit practical about these ex-mine workers, or rather say, Mines and Works Compensation Fund. I will get used to. Dr. Berry, I know there's overall 10 billion rand that must be, it can be less now because you've been, in a process of paying ex-mine workers. So as this is an unfunded mandate, Chair, I want to hear from the Commissioner what steps so far have you taken to ensure that this unfunded mandate becomes funded, because you are implementing this project in provinces, and I know some of the provinces are struggling to implement, or rather to track and trace these ex-mine workers due to lack of resources. So I want to know from the commissioner if there are steps taken, or maybe chairperson, as you were part of this committee in the 6th administration, maybe there are resolutions that were taken in the past which we might not be aware in terms of this particular unfunded mandate to be a funded mandate, so that we achieve, the commissioner achieve the goal. Thank you, Chair. Oh, Chair.
Okay, yes.
Sorry, my apologies. If I can just mention and also commend the Harmony Mine. Last week we had an oversight visit to different mines, but I was in another committee, not with health. I was with Minerals and Petroleum Resources Portfolio Committee. So in all the mines that we have visited, in terms of, I believe this is also addressing what happened in the past, not to happen again like now. So most of the mines are really having measures in place in terms of making sure that, especially when coming to silicosis and TB in the mines, in terms of control and also prevent and make sure that those who are infected, they get necessary support. But I want to mention this particular mine that is doing very, very well, and they are also part of assisting the commissioner in terms of track and tracing the ex-mine workers, which is Harmony Mine. I was really impressed with the work that they've been doing, and they are continuing to do in terms of this particular a project in their mine. They even call it reconnect. They reconnect with the ex-mine workers and also the current workers in terms of their health in the mine. But I'll share more when we meet properly, not in this platform. Thank you, Chair.
Thank you very much for that input. Honorable Van Staden.
Thank you, Chairperson. I've just one question, and that's on the expenses over 399 million. Can the Commissioner just elaborate a bit more on that? Was it for compensation, or for what exactly was all that money used for? Thank you.
Thank you. Honorable Clark.
Thank you, Chairperson. Just a few quick questions. I'm a bit disappointed that we've transgressed this time, because last financial year you did have a clean audit with no findings. Can you just tell me how you're going to manage your consequence management, and how the actions form part of your mitigation other than the health department, but through your department? And is there timeframes put in place to deal with your collection revenue? And then how much longer will it take to digitize the rest of your files? Because you've got a very impressive new system. Is there a timeline put in place? And do you have any data in terms of mitigating your programs? Sorry, leave that one out. This was for another question, another one. If you could just tell me your cumulative outputs, how is that broken down? You said part of it is formed through interest, but is there any other component that forms part of your accumulated outputs? Thank you.
Honorable Dr. Leroux. I don't know whether. Yes, yeah.
Thank you, Chairperson. Thank you for that presentation. I just wanted to quickly check two things. The one is around the income of the fund. I see there's quite a lot of tax that comes in. Interest that comes in from the size of the fund. Obviously, I think 466 million rands, if I understand it correctly. I just want to see, is there any tax payable on that interest to SARS, and so how does that work? And then the second question was just a more of a practical question around the people who we're still struggling to find. I had mentioned that with my networks through rural doctors, we could certainly use that. Is there a brochure or something available, or an electronic document, or even an electronic brochure available that we can put out on WhatsApp groups so that people can become more aware of how to claim these things? If there's something like that available, I would be much grateful. And if not, perhaps we could put something like that together. Thank you.
Dr. Tembekwayo.
Thank you, Chairperson, and thanks for the presentation. The following are the questions. What are the challenges faced by the inspectors when conducting inspections? How have these challenges been resolved, and how often is the mine inspected in the year? And by when will the pool of inspectors going to be increased for greater outcomes? Has there been any resistance from the mines for inspections? If yes, please explain. And the last one, explain the innovative ways of tracing and tracking ex-miners for their unclaimed benefit. And I just would like to ask whether you have considered the IEC app as one of the innovative ways of tracing and tracking ex-miners. Thank you, Chair.
Yes. Dr. Kisnasamy, please share with us, maybe if you can, a bit more than just saying there's a fraud case that you're investigating, without mentioning names. If the matter is still to be properly investigated, you can expand a bit on that. Number two, we want to commend you for the work that you are doing in actually, of course, there's that pace of compensating our people all over. I'm just following up on the Honorable Sene's question that you are doing this, that, and that probably well, but you will know that there's a big cry from neighboring countries where we are not really seeing your visibility there. Probably is related what Honorable Sene was saying, that when you go to Eastern Cape and Northwest, by the way, those provinces have done exceptionally very well. You do expect them to focus some resources to make sure you travel this and that. And maybe that's a limitation in you actually doing much more than what you could have done if resources were available. But what about neighboring countries? We seem not to really be able to move there. Is it because we are really not having enough to go and do that work? Because there are people there too who actually have needed our support. You know, our visit to Mozambique, the former president is saying, but when are you going to pay our people here? People came in and made this country to be what it is. In return, they have not received what is due to them. We would probably want to take this matter to a higher level than just us in terms of getting all members of parliament, maybe having this as an item in their constituency office, check up awareness processes like what Honorable Leroux is asking. Is there a pamphlet or a leaflet? But I think it's just more than just us here in this committee, much more, and a lot of other other parliamentarians should be receiving this information and assisting the tracking and testing, and then see how that process gets to be done. I would be interested to know, now that in your closing remarks in the slides, you showed quite a lot of other institutions, bodies, unions, and that you're actually working with as to, now that in 2024 December, South Africa will be taking presidency of the G20. And there's a desire for G20 to impact not only to South Africa, but to the whole of, not only of SADC, but to the whole of AU. What would you advise, or what would be your strategic thinking and plans to make sure that the G20 has an impact to Africa, especially on these issues of mines and the compensation of miners? We are delighted to learn, but do confirm what Honorable Sene is saying, that what we are busy here with is the compensation of the former mine workers from 1965 to date, but we are confidently saying, unlikely that in 20 years' time we'll then be saying the miners that were there in 2022 were again not being treated fairly, and therefore we must go back and look for their compensation and get for another share miso trust type of an activity. We want to say this may have its end. And the lessons that have been learned that has brought us to be dealing with what we are doing here now are not going to carry on and on and on forever. What Honorable Sene is saying is reassuring, but you need to also confirm, maybe ourselves as a committee, we need to go and see that there should not be in 2040, 2060, other undetected or untreated silicosis going back to Shai and to Libote, when it could have been prevented or be detected on exit or on entry of ex-mine workers. So let's probably then get you to assist us with some responses on that.
Thanks, Chair, and really appreciate the engagement of the portfolio committee members. So let's kick off. Firstly, thanks for the salutatory messages, and to Honorable Clerk, we were quite worried that we had regressed, but it was related to the funding requirements of the PFMA, and I think Auditor-General has mentioned that it was almost impossible in terms of that. But I'll come back to your questions fully, Honorable Clerk. So, Honorable Klergo, the measures within the fund on the fraud issues. We think, as you know, there's a sampling that's done by the Auditor-General, and there's also internal audit. So there's two structures that we work with: internal audit, which is through the Department of Health. It's a co-source function which undertakes various activities. And then there's, of course, Auditor-General. And we've had a clean bill on payments, since the 2013 year, and of course, revenue since 2018, and of course, the inputs on it. So on the payment side, we had investigated 3 levels of fraudulent activities. The one is administrative fraud, which is the changing of IDs, changing of passports, changing of information of the individuals, particularly deceased, death certificates, etc., Master of the High Court in executors. So we've got a team, both a forensic team, which has been funded by the Minerals Council that supported us, as well as Dr. Botus leads inputs in terms of this field. So from moving away from the physical files, that was the one issue to curb any issues. Look, these things might have happened in the past, but in terms of currently, we've got a very strong process in place in terms of electronic checking of records, etc., in terms of ID links to Home Affairs. The problem has been neighboring countries, and I'll reach out in terms of Dr. Dlomo's points, because a third of our ex-mine workers come from neighboring countries, particularly Mozambique and Lesotho, and that's been a bit difficult in terms of electronic databases, Home Affairs, etc. So the first is administrative fraud, and we think we've managed that. The second one is clinical fraud. So we do note that a chest X-ray, a benefit medical examination, and we now have an online lodgement system, which we kicked off, which is worked jointly between us and Shia Miso Trust. And the checks and balances are in terms of the chest X-ray, digital chest X-ray. We used to have what I call analog films previously, which could be fudged, because a analog chest X-ray could be valued at about 30,000 Rand, 40,000 Rand in terms of silicosis. And we do recognize that claims can be put in and the chest X-ray swapped in terms of a new claim. So that's been overcome now in terms of the digital process, where you can't fiddle with the systems in terms of a digital X-ray. And some members of your committee are medical, so it's almost impossible in terms of this. So to play around with it, and there's checks and balances in place from the time of lodgement, a benefit medical examination. These are all now electronic. And we've also picked up on the issue of analog films and digitizing the analog films. That's why we went quite ahead on digitizing the films and images and actually putting into that. There's two other aspects related to clinical aspects. The one is the new revenue database, which Dr. Dlomo mentioned, that what are the lessons learned about 20 years from now having to do tracking and tracing again? Well, we're hoping that 20 years from now, there'll be zero TB in the mines, at least, and zero chronic lung diseases coming through from the mining sector. And I see to acknowledge the leadership of the Minerals Council here, and it was very good. I see the colleagues also from Harmony that are here in terms of the work done by Ms. Senna in terms of the oversight visit. So with our work that we're doing with the mining companies and inputs and the revenue database has gone live. We're currently covering about 80 mines in terms of the risk shifts and invoicing and checks in terms of it. But as of July next year, we will go with medical records from the mines in terms of the database. So every risk shift, there'll be a database of all mine workers, but there'll also be a database of those who do risk work, and the medical records would go with it. So we're building quite a strong database, which would be the original act, the Miners Thesis Act, covered cradle to grave. And we are in strong discussions with the Minerals Council led by Dr. Machali and Dr. Balfour in terms of the cradle to grave input. So we are hoping that the clinical issues and clinical fraud and lessons would be minimized in terms of not having to go and track and trace. So firstly, prevention, intervention. So not having, this fund should not be there actually. And secondly, with the clinical issues in terms of clinical fraud. The third issue is related to banking fraud, bank accounts, because we are not like SASSA where we pay cash. We have to pay bank accounts. So that was the third issue about working directly with the banks. We have special audit trails that check the bank accounts because there's a checking the bank account against the individuals, etc. So in general, we think we've managed to prevent any fraudulent activities, and with the internal audit and external audit and the forensic team making inputs in terms of that. I'm going to talk a bit more about the consequence management in a minute, but let me just stick to then the issues around the fraudulent activities of the fund and risk. Now, the problem we've had in the past is the touts. The touts goes to Ms. Cego in rural Amzimkulu and says you've got 20,000 Rand in Johannesburg, then opens up the bank account for the individual, holds the card. We pay into Ms. Cego's bank account, but she's got no control over the bank account. All the time, 100,000 is paid in terms of it. She's illiterate, in inverted commas, in financial matters, and the tout then, with the card, withdraws the money, splits it between the syndicate. This is the syndicate, Dr. Dlomo, that we are talking about that was operating in Limpopo, that's currently being prosecuted in the Palm Ridge Commercial Crimes Court. This was a syndicate that was operating, that was doing these things, including taking people for benefit medical examinations, opening up bank accounts of individuals, etc. So that process now is we pay into, she is the legitimate deceased wife, spouse of a deceased mine worker, but she has no control over the account. And on top of it, the 20,000 Rand is then given to her and told, you've got to give us 2,000 Rand as a 10% facilitation fee. 18,000 Rand is still a lot of money in a rural area. So those are some of the issues. By working with the provinces, working with legitimate structures like the Ex-Mine Workers Association, the Office of the Premier, and colleagues on the ground, we've managed to overcome some of these issues around the touts and also preventing them from coming to the MBOD, CCOD. So I hope that helps with, you've got to try and minimize as much as you can in terms of fraud, but there's been no losses to the fund, but there might be a loss to an individual outside the fund. The risk strategy, as part of our annual performance plan and the strat plan, we've got a risk strategic framework. We've got an operational framework, and that's updated and presented to the Audit and Risk Committee. And we've got a senior deputy director who is a risk manager that works with the risk control officer at the National Department of Health. So that's in place, and we can make available that to you, which goes through high-level risks, moderate level risks and, low level risks. And essentially what we're doing about the risk mitigation issues, business continuity plans, infrastructure plans, flooding of the buildings, the internet being down, etc. So we do have that in place, and it's part and parcel of the reporting to the Audit and Risk Committee and also to the Auditor-General and to internal audit. The question of 10 Rand in 2010 and 20 Rand in 2024, unfortunately, this is a problem. The fund pays on the basis, in terms of the act, the current act, it's the date of the medical assessment, the medical examination. So whatever the amount was due at the date of the medical assessment, that's paid. The only time it increases, and you've raised a very important point, and I can't get around that, that part of the act. So it's the date of the medical assessment or the date of the post-mortem finding. And if it's paid and rejected, then there'll be interest accumulating from that. But unfortunately, I think you've raised a very important point. It's a sore point with many of the deceased claimants, as well as, where we've tracked and traced and then paid people. But it's unfortunately paid on the date of as at the date of the medical assessment and what was the recording at that stage of the amount. Ms. Mama might want to talk about that a bit more later on, depending on how we're doing on time. Honorable Senna, thanks for your work and your previous life. You ran this program in Northwest, so you're very much up to date with some of the issues that faced us. On the unpaid funds of 10 billion, that includes the Mine Workers Provident Fund. It includes the Shemiso Trust and some of the other class action. It includes the Unemployment Insurance Fund, and it includes our fund of 1.3 billion. And then I also mentioned previously to the Portfolio Committee the deferred pay scheme of TEBA, where monies were held back from the mine workers, migrant mine workers, and only paid back. And much of that money then got merged into African Bank, from the TEBA Bank into African Bank. And it's some of the issues that we need to pick up. So it might be that your Portfolio Committee Chair needs to pull a meeting together on the unpaid social protection funds with National Treasury that deals with this issue in terms of the unpaid funds and how do we actually unlock. There's 10 billion for the mine workers, but there's overall between 60 and 80 billion in terms of workers in South Africa were due unpaid social protection funds. And Dr. Botas attended a workshop 3 weeks ago on unpaid social protection benefits. And we are suggesting that government has not taken a handle on this other than my fund, which we've done a fair amount of work in terms of being actively pushing the fact that the money is in a bank account in Johannesburg and how do we reach out in terms of this. So somebody needs to take a handle on it. And at the moment, it's not there within government because this is wider than us and it deals with the finance and the Financial Sector Authority, which is regulated by National Treasury, etc., on unpaid pension and provident funds. So we're hoping that your committee could be the stimulus in terms of pulling this together with the Department of Social Development, National Treasury, and some of the private sector issues. Although Nix Lesofie has tried to pull this together as well, and we do appreciate what the Minerals Council is doing, and of course, we're working closely with the Shemiso Trust. On the unfunded mandate, I don't have any answers on that. It is a problem for the provinces and even worse for the neighboring countries because, Dr. Dlomo, you will understand that a Ministry of Health has a mandate to look after the citizens or the people who travel within South Africa. So it was very unique when I raised previously with Minister Motsoaledi, then Minister Pashla, that we have to provide these services in neighboring countries. And the key area in terms of this with the neighboring countries was then, how do you contract service providers, etc. So Dr. Machali, has the tender that they put out was mainly covering South Africa in terms of the service providers. So that will be in place. We have to discuss with our CFO about how do we contract with service providers outside South Africa. So the unfunded mandate is real. National Treasury has told us there's no money, even for the infrastructure for the Section 3A entity of the fund, as I mentioned to you all, as a problem. But in terms of service delivery, Minerals Council has assisted with some funds, but I don't have any answers on this. Of course, we will be, in terms of if I manage to, when, because the question is now the repeal of the act. The mining companies are quite keen, as they understand the levy, that will cover everything, and government could slowly pull out of the funding of the administration. So it will become a funded mandate once we repeal the law. So the key area for my role over the next 2 to 3 years is basically to get the repeal done through your committee in Parliament. And then, we're raising 400 million in interest payments alone. But in terms of the current act, we can't use any of this money for service delivery purposes. So, Honorable Senator, I don't have any answers on that unless the portfolio committee has some teeth in terms of the budget discussions and can actually pull it together. And I just saw a note from Honorable Clark about at least if your committee could kick off, and we would support technically, Honorable Clark, if this committee could take the cudgels up on unpaid social protection benefits. It is a major anti-poverty alleviation. The monies are due to the workers, and to make inputs on that. So thanks for your comment on that. So I don't have any answers on the unfunded mandate other than the repeal of the act and inputs around that. Thanks, Honorable Senator, for your inputs on Harmony. I'm sure there are other major mining companies that are also delivering a similar agenda. But what you saw at Harmony and the Operation Reconnect was fantastic. That they've helped us with, and in fact, Dr. Machali is seconded from Harmony. Dr. Rabada is seconded from Goldfields, but these are colleagues paid for now by the Minerals Council, and ethically they've delivered the goods as well, and working closely with colleagues like Dr. Lawazi, who's on the site. I don't see the other colleagues from Harmony here, but I think they will take back your comments quite well in terms of one of the companies that's making a difference. Honorable Van Staden, I don't know, the 399 million. Do you know the slide offhand? Because I don't have the slides in front of me, and then I'll come back to your question. Either Ms. Mama will respond to it. So if you can just put in the chat, what's the slide number on the 399 million, so I don't misquote you. So if you could just do that very quickly, and then I'll come back to your input on what is the 399 million made up of. And Ms. Mama will respond to that. Honorable Clark, you've been a supporter of our reforms and input, so we do, are concerned as well about the issues around. Let me just get Honorable the chat. The issues around, the regression a bit, although it's still an unqualified audit, but the issues around inputs on consequence management. There's two things that have happened. We have a forensic team that's commissioned by the Corporate Services Directorate within the Department of Health, Dr. Percy Maslati, and that team has started working as of 2 weeks ago, and has met the team in terms of the consequence management, the investigations, and working through the background. We're not too sure how long they'll take, but at least there's a formal team now appointed by the National Department of Health. Remember, we are working on consequence management on the civil servants, and hence I don't have direct jurisdiction as a 3A entity in the fund, because the MBOD CCOD is part of the National Department of Health. So we appreciate the fact that Dr. Maslati and the team at Corporate Services have brought in a team, and we'll find out from them what's their timeframes and inputs. But they started working 2 weeks ago, and we've made representation to them. The timeframes for digitization, that's difficult. We had put out a tender for this. This was previously supported by Rand Mutual. Dr. Rabada is in further discussions with Rand Mutual about whether they would continue with the project. I'm not too sure if any from colleagues from Rand Mutual are on the input to hear that this is a very important project, but it is an ongoing process. We've got another 400,000 files to digitize, so we would appreciate some support. But we did put out a tender, but there's some dynamics in terms of the quotations related to digitization. On the cumulative outputs and the interest, again, Honorable Clark, if you could just refer us to that slide, and then we'll get back to you through Ms. Mama when I conclude on this issue in terms of that process of the cumulative outputs, which is mainly interest. So we only get income from the interest and income from the levies, and that's the only two sources of income. Of course, there's transfer payments for the old pensioners. That's about 1 million a year in terms of the pensioner grouping, in terms of the old act, because we don't have any pensioners anymore in terms of the new act, the 1973 act. Dr. Leroux, thanks for your input. In fact, the RUDASA has invited me to speak at the conference, and I've gladly accepted. I'm sure you had a role to play in that since my discussions with you at the induction committee. So I do appreciate the fact that I will be speaking at the Rural Doctors Conference. We do have our website and things, but the brochures are outdated, so we'll have to prepare that. And Dr. Mitchali and them will be very keen to set up a training program which we can fund. We've got some funds from Minerals Council, which will help for an outreach online virtual training platform. And I'm committing to that process, notwithstanding that I will be speaking at the RUDASA conference later this year. So I do appreciate in terms of that process. The income of the funds, the 466 million is correct from interest. We don't go into dubious bank accounts. We are not sitting with VBS, etc. So we are in good bank accounts, and the Public Investment Corporation and ABSA and First National Bank and the Public Investment Corporation. And we've enjoyed fairly good, decent interest rates in terms of it. But we can't use the interest rates, the interest payments for anything else other than growing the fund in terms of the process. So that's been the difficulty in terms of the flawed act. Remember, I pointed out at the induction meeting, this act was set up to look after white mine workers between 1912 and 1973. So the state ran the benefit medical examinations, ran the entire system for white mine workers, what are called the red ticket examinations, the periodic examinations, the pre-employment examinations. So it was a system that the state had to run, including the administration of fund. And historically, the state cross-subsidized the fund by the administration. So it is a problem compared to the funds in other social protection funds. Very uniquely for tax, no, this is it's a tax-free fund. So we don't pay tax on this fund. Neither the beneficiary nor us as a compensation fund pay tax to SARS. So it's written into the act. The Commissioner for Internal Inland Revenue, I think it's called, in the 1973 Act. This fund is not taxed, which has been a major game changer for us because when we track and trace individuals, we don't have to get a tax directive, which has been quite a difficult process with some of the other social protection funds, as well as the Shiamiso Trust. So we are tax-free in a sense, both in terms of the fund, as well as in terms of course, we do pay VAT in terms of the actuarial valuation and bank charges, but that's about it. But there's no income tax payable to the beneficiaries. So the rural doctors we've covered, and I'll continue an offline discussion with you in terms of the input in terms of that. I see Honorable Van Staden, Ms. Mama, it's in the chat about slide 18, if you can prepare for that. So the RUDASA thing is covered. Dr. Tembekaya, always good to hear from you, Honorable Tembekaya. The challenges by the inspections, no, we've had a very favorable route. The mining companies and the quarries and the works have been very supportive, not turning us away. The challenges have been mainly ruralness. I mean, to get to Katu, it takes us, or to the manganese mine, in Ottazal, there's a big manganese mine, and there is a place called Ottazal in the Northern Cape. It'll take us virtually 2 days. By the time you get to Kimberley, you fly and then you drive to get to the Samanco mine or the Venant, the copper mine, up near Priska, or, these kind of things. So it's been quite a problem in terms of access, in terms of physical roads, and the 3 inspectors do a great job. We don't have funding for more inspectors. Again, that's part of the issue around unfunded mandates on service delivery, unfunded mandates on state accountants that can function as accountants. But we've done what we can together with the support of the Minerals Council in beefing up our inputs. And under Ms. Baolo, the Revenue Deputy Director, they've done a great job, notwithstanding the issues around the inspection. So the mines have been very open, no problems in terms of the challenges. And, we've had clean audits because Auditor-General also does routine audits of the mines to check on the income together with the internal audit section. the innovative ways to track and part of the issue now is the online revenue database. So we've had the online payment system. We've now developed with the funding from Minerals Council the online revenue base, which is now state of the art. It's been rolled out to 80 mines currently, and will cover all 300 over the next 9 months or so in terms of the revenue levy shifts. But thereafter, we'll go after the clinical records as well. So it's going to be the state-of-the-art clinical and administrative records, including TB incidence rates and dust levels in terms of the process. Innovative ways to track and trace. I did mention this before, but just to reiterate, firstly was the electronic database. Secondly was the use of the call center multilingual. Thirdly was the outreach activities where we physically, and we'll invite, I have sent an invitation. I'm not too sure if you've been circulated to yourselves. We have an outreach in Tabanchu next week, and physically we go to the ground. We have an outreach in Mpumalanga. We haven't yet tackled the neighboring countries, as Dr. Dlomo has said, because of funding constraints. Historically, we've been in Northwest and the Eastern Cape, so that's been part of the issue. And then the third issue was we work with multiple databases, ShopRite Checkers, Capitec Bank, SASA, Shia Miso Trust. So wherever we can try and find an individual through a database, then we reach out to the person, and our either then through tracking and tracing on the ground and using unemployed graduates, as I pointed out before in a previous meeting with the portfolio committee, as well as through the call center, where the call center will call up the individual and then we try and get a completed pack. So there were some innovative ways, and we're quite happy if committee takes up this resolution of Honorable Clerk, then how do we actually pull this together? So, because we could do more if we came together as the Mine Workers Provident Fund, Shia Miso Trust, the Compensation Fund, Unemployment Insurance Fund, the Deferred Payment Scheme of TEBA. Our database currently has the Mine Workers Provident Fund and the TEBA database, which will say if there's an unpaid claim in terms of the Shia Miso Trust or input. So there's been some cross-linking of databases where an individual knows that there's a potential benefit from another fund. But we hope that your committee will call a special meeting with National Treasury and Social Development, and we can pull this together. So we have done quite a bit, and overall, I can't remember the figures now, but I think we've paid out now close to 1.5 billion to 30,000 claims, over the last 7 years. And that made up 50% of the claims over the last, 20 years. And this was part of the innovations. Dr. Dlomo's point again, thanks, Chair, for your support to us historically and currently. The fraud case is related to a syndicate that was operating in Limpopo in Polokwane that would physically generate false benefit medical examinations, generate false bank accounts and inputs. And thanks to Minerals Council, this was tackled, and ultimately the case was launched with the SAPS in Hillbrow. There was another case in Klerksdorp as well, which was also, we've reported 3 cases, Klerksdorp, SAPS, and 2 at Hillbrow. The Hillbrow one, the Hawks got involved, and ultimately the National Prosecuting Authority, and ultimately that case is continuing now, was noted in terms of 3 individuals involved. It's a family-run syndicate, of course, with runners and touts. But we'll keep your committee informed at other meetings as it is. The next meeting that the State Advocate will be pulling in is happening towards the end of October. Unfortunately, it takes about 2 to 3 months. There's been stalling procedures, sickness notes, etc., that have been going through. But we're hoping that it'll be a successful prosecution in terms of the individuals, because we've got the documentation, we've got the physical files, and we've got the evidence that's led to this process. So we'll have to see how that fraud case unfolds. The neighboring countries I've mentioned, it's similar to Honorable Senna's point about the unfunded mandate, and I'm going to need budget support in terms of taking this forward, as well as then the cross-border delivery of services in terms of this. You've raised an important point about the G20 and South Africa's leadership, and we've been quite involved, and that's why thanks to the colleagues who are on the call from all corners of the earth who have been very intrigued by the work we do. This is one of the few funds that deals with mine workers and occupational lung diseases. Because in many countries of the north, they don't have this burden of disease in mining. You know, Canada, Brazil, you know, Russian Federation, etc. China has a bit of the problems of silicosis and coal workers' dust. They want to learn from us, and China and India, major problems with silicosis, again, some work to be done. So in terms of the leadership of G20, I hope, Chair, that you'll put on the agenda occupational health in general, and TB in mining in particular, or occupational lung diseases in mine workers. But occupational health and safety is a critical area overall. Of course, leadership should be between the Department of Employment and Labor and Department of Mines. But let's see where we can come to it in terms of the work. In South Africa's leadership in terms of the African Union, we've got the lessons from the TB in the mining sector project, which we'd be quite willing to share with you. There is a close-up report towards the end of November that Minister has been asked to speak, and I hope that we can extend an invitation to your office. And Minister has passed it on to me in terms of the TB in the mining sector, which was a global fund program for the countries in Southern Africa, the SADC countries, on bringing up the issue of occupational health in the mining sector, the artisanal and small scale miners, as well as service delivery for them. And Nix Lesoufi is quite involved with the Minerals Council and the SADC-wide protocol as well, notwithstanding the SADC protocol on TB in the mining sector. So we're hoping that you've raised an important point about G20, South Africa's role. I've played an important role in supporting the BRICS initiative with Norbert Njeka, and together with other colleagues in occupational health, notwithstanding the trade unions, International Labour Organization, we'd be quite willing to share the lessons about how in 15 years we dropped TB in the mining sector in South Africa from 2,500 per 100,000 mine workers, 10 times what the World Health Organization says is a catastrophe. 250 per 100,000 is a catastrophe, what the WHO says. And we dropped it to, in 15 years, to 250 per 100,000. So we must commend the mining sector, of course, the social circumstances that's come about, the single-sex hostels, the overcrowding, the HIV pandemic, the COVID issues that hit us, etc. But I think we are delivering the agenda. And very importantly, tomorrow starts the mining summit. And very importantly, Chair, I've raised historically a thing called the occupational exposure limit, which was up to now 0.1 milligram per cubic meter, the dust level. Canada is 0.025, Australia is 0.5. Chair, the Minerals Council, the Mine Health and Safety Council has decided on a limit of 0.3 milligram per cubic meter. So we have to congratulate them in terms of bringing down the dust levels, because they're the statutory organization. And maybe our dream that by 20 years from now, we have no occupational lung disease and no TB in mining. Chair, I'm going to hand over to Ms. Mama. Ms. Mama, it's related to slide 18 and slide 19. Ms. Clark and Honorable Clark and Honorable Van Staden. Ms. Mama, through you, Chair.
Thank you, Dr. Berry. So to answer to Honorable Van Staden, and going to slide 18, it does show the background, the breakdown, and the majority of the expenses is in the provision for unwinding costs of, and with a liability of 283 million in the current year. Thank you, Chair. Maybe Gert can add.
Thank you, Chair. Thanks, Tembi. Through you, Chair and Commissioner. So just to explain how that works, the unwinding of the provision. So when the actuaries provide their final report, they actually sort of calculate the total outstanding claims that the fund might get now and into the future at the current point in time. So what would happen is that amount that is calculated for this point in time into the future is then discounted back to a present value in terms of the time value of money. So every year that passes, that unwinding as such of the interest cost that was discounted needs to take place. And the opposite of that is that the income statement is not hit by claims payment during that period. So the claims payments are actually then offset against the provision. But the movement in our expenses relates to the unwinding of the provision and is classified as finance costs. Thanks, Chair Demi.
Chair, have we answered Honourable Clerk? I think we've covered Honourable van Staden. Honourable Clerk was about the 3.3 billion surplus in 2024. So we've dealt with the interest and inputs on that. Honourable Clerk's input on the 3 billion. Tembi or Kert?
Chair, maybe through you, I'm not sure exactly what the question related to for the 3 billion surplus, but just important to note the difference for the Mines and Works Compensation Fund. As the Commissioner and I think Mr. Mashinwane stated, is that the fund is only allowed to pay the actuarial valuation, bank charges, and claims payments. So our accumulated surplus is somewhat different to the normal operating entities in terms of Section 3A, where the accumulated surplus would actually be passed back to Treasury. We also have a sort of a fluctuation in terms of the accumulated surplus, in terms of the actual valuation or the provision calculation that's actually sort of performed on an annual basis, even though the fund, the Act requires it to be done every 3 years. If that would answer your question, also, Honourable Clerk, welcome to clarify the question. Thank you.
Chair, through you, thanks. So, our surplus funds are not sent back to National Treasury. This is purely for the purpose of the currently 5.8 billion fund. Which will grow, and this is the funds of it. So we don't send back funds to National Treasury. But Chair, through you, I'm not too sure if there's any further inputs from Honourable Clerk or Honourable van Staden, but I think we've covered most of the inputs, and thanks to the members. Over.
Yes, you have covered everything, and the Honourable van Staden has just indicated to me he's very happy. I am on my cell phone now. My laptop is angry with me that I have been on the line for the whole day. In any event, we are wrapping up. Thank you very much for, and Honourable Clerk is also happy. Thank you very much for the this presentation. It just shows how much you passionate all of you here are on this program. And thanks for sharing with us some of the responsibilities that we need to take forward, because this is just not about us, it's about all other parliamentarians to know what can we do to make the lives better of all citizens who once were associated with the mines for the past. But we are glad to hear that things are very much in space, well looked after, and the presence of Mr. Nix Lesotho in this meeting again and all other Mineral Council members is really confirming that you are up to the game. Thank you very much for that. I think we want to leave it at that, and thank you once more, and say go back to where you were, unclaimed audit outcomes next year, and we hope all the best for yourself. Thank you very much. Honourable members, as they exit, may I request that you note that tomorrow we are starting at 9:30, and that's a good time, at least after breakfast, for those who would like to have breakfast. And you will all have a tea time. You must just have a glass of water, a tea next to you as we start the meeting tomorrow until lunchtime. Thank you very much and have a good evening. Thank you very much and have a good evening. Find time to go and watch Bafana Bafana. Bye-bye.
Thank you, Chair.
Thank you, Chair.
Bye.
Thank you. Bye-bye.
Bye.
Thanks,
Bye.
Recording stopped.